Yes,
Yeah. So can you tell me what are the precipitating factor for acute porphyric attack?
there may be drugs, then there may be hypothermia,
Full
then
of few.
hypoxia,
Huh?
intraoperative stress,
Huh?
and chronic use may be there.
Huh?
Then acidosis.
Okay. Fine. So you mentioned you will assess the patient pre-operatively. So in that, how do you optimize them?
We will look for the hemoglobin levels,
Huh?
and if there is anemia, we can give blood transfusion, or if there is time, we can give heme injection, any
Huh?
iron injections, and we
Huh?
will also look for any associated features like any abdominal pain
Okay,
or
the patient
anything.
gives you Dr. Aditya, patient gives you a history of glucose. So do you think something important you are missing in pre-operative optimization?
This history of, can you repeat your question?
The patient gives you a
Mhm.
history that the patient was taking glucose. Would you
Okay.
like to do anything?
I would like to have the blood sugar levels in
Uh,
this case,
uh,
and because there are chances of, I think, hypoglycemia in acute intermittent porphyria.
uh. What else you
So
can
sugar
do?
levels have to be maintained.
Mhm. Okay, what are the anesthetic agents that are safe and unsafe in porphyria among the commonly used drug that you use in your practice?
Barbiturates like thiopenton are generally considered unsafe. They may precipitate the porphyric crisis,
Uh,
and we can use propofol.
uh,
Then opioids may be used
uh.
as an analgesic,
Which
like
opioids? Can I use fentanyl?
short-acting opioids will be better, like fentanyl.
Mm. What about ketamine?
And ketamine, I think, can be used,
Uh,
and cardiostable muscle relaxants can be used, like vicuronium and rocuronium.
uh.
And we can also use the inhalational
Okay,
agents.
what is your anesthetic plan for the case? Like you have to tell me what is the drug you're going to use for induction, what are you going to use for maintenance, like that.
For induction, I will like to have a cardiostable induction with propofol and remifentanil.
Uh,
And for muscle paralysis, we can use muscle relaxant. We can use vicuronium and rocuronium, and
uh,
we can also use sevoflurane for inhalational maintenance anesthesia in
uh,
this case.
uh.
And we would like to avoid nitrous oxide.
Okay. So what do you
And
want to, like you want to hyperventilate, hypoventilate or normoventilate? And why I'm asking this question?
uh, we can go for a mild hyperventilation in this case,
Uh,
because there may be associated CNS symptoms
uh,
which may lead to cerebral edema.
uh.
So it will, or in acute settings, it will decrease the partial pressure of carbon dioxide and will also relieve the prevent the cerebral edema. And
So,
we'll
what are the
proceed with the
major
endotracheal
post-operative
intubation.
complications? What are the major
No,
post-operative? What are the major post-operative complications in porphyria?
there may be chances of hypoglycemia.
Uh,
Then anemia,
uh,
abdominal pain,
Okay. So, one
all
hour
these.
post-operative, the patient become very much restless and is complaining of diffuse abdominal pain. Okay. So, after 2 hours, you notice patient was tachycardic, hypertensive, and complains of muscle weakness in her legs with increase in the neuropathic pain. When you did a blood gas, hyponatremia was there, metabolic acidosis was there, and the lactate was normal. Okay. Did you get the
Yes.
question or you want me to repeat?
Yeah. Hyponatremia, metabolic acidosis, and lactate was normal post-operatively.
Yeah. So can you tell me what actually is going wrong? Hello?
There may be any intra-abdominal bleeding,
Uh-huh.
and
So the patient is having hyponatremia. So what are the differential in your mind which can lead to a better answer? Like what can be the issue?
uh, like any congestive cardiac failure or any kidney failure or liver failure may be there associated.
Uh-huh. Can it be acute porphyric crisis?
Yes, it can be acute porphyric crisis.
So how do you manage a acute porphyric crisis?
I will proceed with the dextrose normal saline drip,
Uh-huh.
and for we will manage the hypotension by fluids and if required cyanotops, and
Uh-huh.
we will also give oxygen to the patient,
Uh-huh.
and we'll give analgesics like opioids for pain.
Uh-huh.
We will maintain the normothermia.
Uh-huh. Any specific antidote kind of thing, which is extensively used in patient with acute precipitate, like when there is exacerbation of porphyria?
Intravenous heme injections,
Mm-hmm.
and we correct the electrolyte balance. Correct the electrolyte balance and the metabolic acidosis.
Mm-hmm. Okay, we'll stop you here. How you felt?
This topic I didn't read, so was not able to answer much questions.
Okay, fine. So I would say one thing. Two questions that are off, too few questions, not two questions, few things that are off bit, but are being asked. One of them is acute intermittent porphyria. Okay. few people have been asked about polycythemia vera, rubra. So this time they have asked about polycythemia, but at times either porphyria or polycythemia, that is one bouncer. If you don't know, you cannot answer. Third bouncer is multiple sclerosis. Then even you won't imagine when it will come to whom. So these are all the bouncer question, which if it comes, if you answer, which people do not answer usually, you will always have a good edge and your confidence will definitely go high if you come, because this porphyria has come as the first Viva of the day. So, to start with the day, it is better if it comes to you and you are able to answer, because though we keep on reinforcing you guys that first exam, you do not try to hamper, like affect the rest of your pro issues, like you should carry with the same confidence, but somehow it has mental impact. So I would suggest, if not very in depth, but at least you need, like how Dr. Nupur, she has some idea, proper idea about porphyria. I want, just you should have a, at least not the best, but at least some idea about porphyria, so that if by chance, because if I say 50 people appear, hardly one or two people get such question. But if you're that unlucky, then you can be in trouble. Okay, that is why I just to show you, like at least, even if you don't have time to revise, at least you listen to me once, that might help you. That is why I put this question. So this is not the topic of your priority though, but something which you should have few idea about it. Okay, and this article has come up in 2021, so you should not don't think that it is had it been not that important, they would not have put it in the latest BGA. Okay, so what happens, porphyria itself are the group of inherited condition that result from partial deficiency in the activity of enzymes that is involved in heme synthesis. Okay, with the one exception of the cutaneous variant, which is caused by the increase in ALA synthase. Okay, so if you see the process, so this is the process. In the entire process, if there is a partial deficiency of any one, so the heme is not synthesized and the process is stopped at one of the precursor level, right? So if you see acute intermittent porphyria, so this is the enzyme that causes the conversion from the ALA to HMB. In the mean process, this intermediate is not formed and ALA is accumulated. Right? It's I think you got delta some confusion here. Dominant. What is the problem? So you need not remember all the variant. Just remember the 4 variant. No need to remember all the enzyme. Remember the one that is for the acute intermittent porphyria. That is sufficient. And what is the condition? It is a autosomal dominant. Then comes the acute neurovisceral attack. That happens. That is very common with the acute intermittent variant. If you have seen here, they have written it is about the acute attacks. Okay. Then I asked you what are the precipitating factor. So, Dr. Aditya, even if you don't know, I gave you a hint. The patient was on glucose. Okay, that means hypoglycemia is one of the precipitating factor. Other precipitating factor are the drugs. Drugs, especially here, they have not mentioned your rifampicin. Okay, then your thiopentone. These are the drugs that precipitate porphyria. If there is a prolonged starvation or carbohydrate depletion, that is again. Third is the fluctuating hormonal levels like pregnancy. Okay, it is also to do with the menstrual cycle. Then is I already mentioned the first trimester. There is excess of alcohol consumption and infection. So I know with the general kind of thing you mentioned about stress, at least what you know, what precipitates sickle cell, you tried to project. That's a good thing that you did, but I would suggest if you know 3-4 things, it is even more good. Then comes, I asked this investigation. Definitely, you want to do the investigation, which will reveal like urinary bilinogen levels, then urinary PBG, the intermediate levels, all the ALA levels. Okay, so the porphyrin precursor PBG and ALA are always increased. So you need to do the ones in your preoperative. You see if there is no acute emergence of the problem. So urinary PBG excretion is significantly increased during an acute attack. Then I came, so here they have given, so if you see, this is the, how do you differentiate between all the three? That also, if you remember or not, that is not an, at least you remember what happens in acute intermittent porphyria. So urinary ALA and PBG will be increased. Plasma, porphyrin, fluorescence emission, peak wavelength will be increased. So this also you can omit, at least to remember the urinary ALA and PBG levels are increased. Okay, so what are the preoperative thing that you wish to do? So thromboprophylaxis is given to all any patient using safe anticoagulation when needed. Okay, second is you have to minimize this. I was trying to focus what is important of glucose. Very important is you have to have a minimum, and you have to put the case as the first case in your OT. Okay, because else it will precipitate. Then these are the what are the safe and unsafe drug? This also I was asking. So among the induction agent, only propofol is safe. Among the inhalational agent, you mentioned about nitrous oxide. Nitrous oxide is safe, rather halocin is not to be used. Among the neuromuscular, all are fine. And then dexmedetomidine, which you will never think is one of the thing that is not, or that is not to be recommended, or it's unsafe. Okay. So if you ask me what is my plan, I will go for induction with propofol, maintain with the Tiva or the inhalational, and drug of choice for your muscle relaxant is rocuronium or atracurium, because you have sugammadex if needed, and if it is atrox, etc., it will undergo Hoffman's elimination. Okay. These are the drug that I have already mentioned. Then you have to ensure the patient is well hydrated. That is also one of the point of optimization. And then it comes, how do you manage the acute neurovisceral attack? Okay. So you have to remove or treat the precipitating factor, exclude the other causes of abdominal pain, go for a more conservative measure like increase the carbohydrate drink. Pain, nausea, and vomiting are prominent feature. So here you have to go for antiemetic, and I mentioned the list. You have to pick up the drug which are safe in porphyria. In ECG, as I already gave you a scenario, there was tachycardia and hypertension. So you need to manage them. The patient was already on propranolol. Also here you can pick up nifedipine. It's a safe alternative. I asked you how, like whether you will go for a hyper or hypoventilation. The point was hypercapnia will precipitate the attack. So that is why you have to avoid hypoventilation. And if there is a neuropathy, doctor, she has also written, if there is no neuropathy, also you can go for a regional technique if that's convenient. Since if the patient has seizure, you have to treat them with lorazepam or diazepam. Hyponatremia is very common. You have to treat hyponatremia, and the fluid replacement with only D5 should be avoided, because that will exacerbate free fluid, will exacerbate hyponatremia, right? And infection and all, whatever there, you have to eliminate. And if it has already happened, like I gave you the scenario, then this is the drug which is important is your heme arginate. Okay. At least about, I remember one of the candidate was even asked about the dose. So if you can remember, it's a 3 mg per kg once daily on 4 consecutive days. Right. So you have to at least remember this few information, which is very crucial. So what are the differential diagnosis? I asked you that question, no? If the patient is having hyponatremia, what are the differential diagnosis? It can be a SIADH. So for SIADH, because again, hyponatremia, you have to check for the osmolality and the sodium concentration. It can be SIADH hyponatremia. You can, and if you want to pinpoint it as an acute porphyric crisis, you can look for the urinary porphobilinogen levels, like ALA and BBG levels. Okay. Now this is the question I wish to ask. Yeah. So do you have any question now? But as I've already mentioned, this is not the question which has to be given a lot of importance. At the same time, if you get an answer, it's good. Any doubt from here?
Hi, ma'am. I want to ask one question. What are the complications of porphyria? You asked this question.
Okay. So you, the second question I asked, no, what are the post-op complication you mean, which I was asking?
Yes, yes.
Okay. So what are the exact question was, what are the major post-operative complication in porphyria? So the scenario which I gave, so if you see there was a acute attack that will be precipitated by fasting, drugs and stress. Okay. Second, hyponatremia. If there is, because there is an electrolyte imbalance here, so if there is a hyponatremia, the risk of seizures will come up. The risk of neuropathy and ileus is very high post-operatively. And because of the prolonged illness, there will be infection and delayed wound healing. Right?
Okay, thank you, ma'am. And with respect to the, you said patient has having diffuse abdominal pain post-operatively. So
Yeah.
so a major diagnosis will be the precipitation of crisis, porphyric crisis, and what else? It can
You
be
ask the differential.
peritonitis or
Can
uh,
be. It can be. It
okay,
can be. So
okay,
how do, like, it can be peritonitis. It can be any, as he mentioned about bleeding. It
okay,
can be
yes.
bleeding, but bleeding will never have a normal lactate level.
Mm-hmm. Oh, yes, yes. Mm-hmm.
Okay.
Okay.
Yeah.
Thank you, ma'am.
Any other question?
One
No, ma'am.
case you are saying that lactate was increased and you was having symptoms after surgery. So
No,
what
no,
will be
I
the
gave
answer
you
for that?
scenario, hyponatremia, metabolic acidosis, and normal lactate.
Yeah, yeah.
Yeah. So normal lactate will, like, see, when you tell about diffuse abdominal, when you tell about differential, how Dr. Sarah told, you can tell anything, whatever, even hypertension and tachycardia. If you would have told me that pain is there, that also I have to accept.
Mm-hmm.
Anything
Okay.
can come in the range. When you want to pinpoint, you have to tell me why you say it's not a bleeding, because normal lactate is there. Why I say it's not a peritonitis, again normal lactate is there.
Mm-hmm.
Sepsis. Why I say it is a hyponatremia, I can think of SIADH. If I say it's a SIADH, then I will have to check for the serum osmolality and your volumic
Urinary.
status.
Mm-hmm.
So, and if when and she was having increased neuropathic pain, then I have to think of the differential of neuropathic pain. So basically you should not keep quiet. You keep on talking something.
Mm-hmm.
Finally, but don't forget to tell the thing of, because obviously and because his patient has a history of the porphyria, and now the symptoms are coming of porphyria. So definitely some acute precipitation has happened, which is generally exam oriented question.
Mm-hmm.
First you tell that. After that you keep on talking. After third, fourth point, they will tell, okay, it's confirmed that the patient is having a acute porphyric attack. So now you tell me what is the management.
Mm-hmm.
Yeah.
Okay. Thank you, ma'am.
Yeah. Okay. So do we have the second candidate who wish to volunteer? See, even if you don't know, if you know, nothing matters. What matters is we need to crack this exam and improve our knowledge. So you also, I wish you also take it in similar way. Nothing to bad that topic is orbit. I don't know at all.
Okay, ma'am. I'll come for it next.
Sure. Okay. So a 46-year-old male weighing 140 kg with a BMI of 42 kg per meter square is posted for a bariatric surgery.
Mm-hmm.
The patient also gives you a history of obstructive sleep apnea and was on CPAP therapy at night, was on liraglutide for past 6 months.
Ma'am, can you please repeat the medicine?
Liraglutide. I will post it in the group so that those who are
Okay.
not able to. Yeah, I posted in the group.
Mm-hmm.
The patient was on liraglutide for past 6 months.
Okay.
Are you okay to start now?
Okay.
Yeah. So can you define what is a OSA?
So OSA is basically a complication. It's a respiratory complication in which there is airflow is limited for more than 4 seconds, and there is pauses in the respiration at night, leading to desaturation for more than 4%, and that's it. And it's a complication of obesity or that's it.
Anything else you wish to add?
Um,
Okay, what are the risk factors for OSA?
for OSA, obesity, chronic conditions like diabetes or hypertension, advanced age, um, and hyperlipidemia, metabolic syndrome. Um,
How do you diagnose OSA?
For OSA, we do sleep studies, which is a polysomnography in which we monitor patients' EEG, ECG, uh, and muscle movement, eye movements, and oxygen saturation.
Okay. Any questionnaire you know?
Yes, ma'am. Stop bank. So in which we ask about it's a questionnaire. So we go for somnolence, tiredness, obstruction, pressures, BMI, age, neck circumference, and gender. And it's more
Okay.
common in males.
So do you know what is apnea hypopnea index?
Uh, it is it is used to categorize the severity of OSA. If it's less than 5, we will not label the patient as OSA. If it's between 5 to 15, we will label the patient as having mild OSA. More than 15 to 30 is moderate, and more than 30 is severe OSA.
Okay. So what are the indication for bariatric surgery?
Mm. Um, it, if the patient is having chronic reflux, the high BMI impairing patient is having cardiac conditions like right heart failure, um, and if it's hampering normal daily tasks, patient is developing metabolic syndrome or hyperlipidemia, and that's it. That's all I can remember right now.
BMI that is recommended for bariatric surgery.
Sorry.
What is the BMI that is recommended for bariatric surgery?
More than 40.
Or means all the patient who's having 40, then only you go for a surgery, or anything else is also there? If it is between 35 to 40, like, do you go for a bariatric?
If the patient is having moderate OSA, or if the stop bang score is high.
Okay.
Mhm.
Fine. So the patient was on liraglutide.
Mhm.
Do you know how the liraglutide act? What is the mechanism of action?
I'm not sure, but I'm just guessing. I think it's an anti-hypoglycemic drug, and it re- it comes under meglinetide group.
Meglinetide or something else?
No, I'm thinking meglinetide.
Okay.
Mhm.
So what is the application in anesthesia? Why I'm so much curious to know about liraglutide?
Because it can cause hypoglycemia, or it can cause hepatic dysfunction.
More importantly,
Euglycemic metabolic acidosis, diabetic ketoacidosis.
anything else important? Would you like to do any point of care ultrasound in a patient who is on liraglutide?
Mm, no, ma'am, I'm not sure.
Mm-hmm. Mm-hmm. Would you like to do a gastric focus?
Mm, no, I'm not sure.
Okay. How do you preoperatively assess this patient?
So I'll start my it involves elaborate history, more focus on the cardiac and respiratory symptoms, patient comorbids, compliance of the drugs, his history of dyspnea, orthopnea, daytime somnolence, tiredness, BMI, and then comorbids, and the drugs the patient taking for this, compliance, any previous history, airway assessment because he's is going to have difficult airway, landmarks, bony landmarks for regional block or any for pain management, then past medical history involving hospitalization and any ICU admissions, previous illnesses, um, and investigations. Will also I will go for complete.
Is it significant in a bariatric surgery? Means what is the implication of OSA in bariatric surgery?
Ma'am, I will, because it will help us in pre-optimizing the patient. He might need CPAP pre-operatively, and he's prone to have respiratory complications in the immediate post-operative period. So we need to have HTU bed available. So,
No, you first tell me intraoperatively. What are the issues
mm-hmm,
on was OSA?
mm-hmm.
Hmm?
So,
And for a bariatric, like both the things you have to mix and tell.
mm-hmm. So pre-operatively, the patient um, um, the patient, we need to have adequate monitoring and staff, and adequate equipment. We need to have mode of anesthesia which is short and rapid, and have rapid recovery, adequate staffing, RAM position, and preoperatively high flow oxygen, and CPAP might need to patient might need. We need to optimize any preoperative respiratory, if the patient is having any respiratory illness, um, because it can put patient at the risk of postoperative complication. Stop bank questionnaire will help us with that, and a patient
Okay.
can
How
have difficult airway.
you're going to manage the airway in a pediatric patient?
If ma'am, we can do RSI. If patient is prone to have aspiration, GERD, we need to have RSI with rocuronium or with sugammadex available, or we can go for fiber optic intubation.
Any spatial position you wish to have?
Yeah, ma'am. RAM position in which the patient's tragus level and sternum is at this patient is high, more than I remember 30 to 40, 30 to 45 degrees with a ramp. That's called RAM position in which the external auditory meatus and the sternum is at the same level. So that will help in preoperatively optimization of the ventilation.
Okay. So what are the key anesthetic drug dosing principle in obesity?
The patient has high some drugs.
I want to ask, there are various type of weights like ideal body weight, total body weight, lean body. So how to, which drug should be given according to what? Like if I'm using propofol, then what is the weight that is considered in a obese patient?
A lean body weight.
So can you tell me for other, like if I'm using succinylcholine, so what should be done?
Succinylcholine is water soluble, so we will take total body weight.
Okay. And what about sugammadex?
Sugammadex, ideal body weight, according to ideal body weight.
And if you're using fentanyl opioids, like I want you to come up and tell which are the induction drugs.
Yeah, ma'am. So propofols, choline, they are according to the total body weight, and the lipid soluble drugs, they are according to the total body weight.
Okay.
I'm not specifically remembering
What are the ventilation strategies you are going to use in this bariatric patient?
We will use lung protective strategy.
Right.
During ventilation. We'll take small tidal volumes. We will use PEEP. We will accept permissive hypercapnia. We will keep the saturations 92 to 94 are acceptable, and judicious use of PEEP.
Fine. What are the intraoperative concern for a laparoscopic bariatric surgery?
Ma'am, it can be divided into regarding the instrumentation, patient positioning, and pneumoperitoneum. Regarding the instrumentation, the patient can have viscous or vessel injury, or Trendelenburg. The patient can have reduced FRC. Patient can have, sorry, can you repeat the question? The implications of
Intraoperative concern in laparoscopic bariatric surgery.
it can have, patient can have low FRC atelectasis, BQ mismatch. Patient can develop gas embolism, and then patient can have a pneumothorax or pneumomediastinum perioperatively. We have to make sure the insufflation pressures are low and they do not compress IVC. Patient can have cardiovascular collapse intraoperatively or arrhythmias. Regarding the position, sorry.
What are the post-op complication?
Patient can develop respiratory failure. He might need post-operative CPAP, HDU admission, and we need to use drugs which have rapid reversal. So
So I'm asking in a patient who is having OSA for a bariatric surgery. Now I'm asking what are the complication of a bariatric surgery?
ma'am, thromboembolism, hypoxemia, arrhythmias, and patient can have residual CO2 in the abdomen, can, and pneumothorax, and
What about dumping syndrome?
Sorry, ma'am?
Have you heard about dumping syndrome?
No, ma'am. No.
Mhm. What is the chronic long-term nutritional concerns after a bariatric surgery?
Mm,
What is
no.
ERA bariatric surgery?
Sorry?
What is the role of enhanced recovery after bariatric surgery?
Ma'am, it can reduce the hospital stay and ICU stay in the patient. It can lead to decrease any wound complications. Patient will have reduce anxiety or cost for the patient and the hospital. So it can lead to the immediate less post perioperative complications, and patient can have enhanced recovery.
So how do you achieve ERAs? And so what are the points of ERAs in a bariatric surgery?
Um, um, uh, Ma'am, there is I'm not exactly sure about the points, but in that we use short hospital stay. We use minimally invasive surgeries, and minimal bowel preparation, and less fasting period, and we use regional nerve blocks for quick pain control, and all these points I remember right now.
Okay. So we'll stop here, Dr. Saragya.
Yes, ma'am.
How you did? I think this is your first Viva with us.
Yes.
Okay. Where do you work?
Ma'am, I'm not working right now.
So where are you based on?
UK.
Okay. Dr. Sarah,
Yes, ma'am.
few things we newcomer. So first, I would like to welcome you as well. When is your exam?
Ma'am is in June.
June. Okay. So, what I see here, your knowledge is good, okay, but there is a lack of structured approach.
Okay.
I think what I'm asking and what you're answering, maybe many a times we are not on the same page. Okay.
Mm-hmm. Mm-hmm.
Second thing is you have to work hard to keep you updated. Like
Okay.
Lira like it is one of the most upcoming topic, and I think in every Viva this is one of my favorite question, and every examiner in EDAIC also nowadays asking this question on liraglutide.
Yes, ma'am.
So
Yes,
focus
ma'am.
is very important. Though this year they have not started asking focus, but last year it was like marathon of focus. Whatever statistics is this year is the same what was focus last year. So you can expect that in the because it's kind of April, May is gone from June, they can start with focus. So you
Mm.
need to have good knowledge on focus as well.
Yes, ma'am.
Because you have less time, I would suggest if because you are not working, you have to definitely work twice of what you are working now.
Mm-hmm. Yes, ma'am.
So I could see few answers of your colleagues who are doing with us for a quite long time, and like they are able to answer because they have been doing the same exercise with us for a very long time.
Mm-hmm.
I think you won't be able to cover our entire topic based by June, is it? Am I right?
Mm-hmm. Yes, ma'am.
We get the access and at least go through each of the session properly. You will
Mm-hmm.
learn a lot. It's not because I am teaching, I'm saying, but definitely your knowledge will improve. At least you will have the updated knowledge. Because
Mm-hmm.
this is what I see your knowledge is not quite updated. You are talking from all the residual knowledge.
Mm-hmm. Yes,
But the
ma'am.
positive thing about you is you are your vocab is good. Your your speed of answering is good. Okay. And
Mm-hmm.
facts are very clear. Things which you know you are answering pretty well. So if you improve your knowledge or you update your knowledge, definitely you will perform good in your exam.
Yes,
So
ma'am.
things I wish to answer, and now I will give you the feedback and will let you know. So can you see my screen?
Yes, ma'am.
Yeah. So first I asked you what is the definition of OSA?
Yes.
So this is the complete definition of OSA. And you 5 seconds, it is defined as a repeated episodes of complete airway obstruction leading to apnea, defined as 10 seconds of absence of flow, and or partial obstruction leading to hypopnea, defined as flow halved over 10-second period, both causing a fall in oxygen saturation. How do you define oxygen saturation fall? Is when the drop is more than 4% from baseline, or the last recorded value for more than 10 seconds, or a SpO2 of less than 90%. So when it comes to definition, when I am supposed to talk the same what is given in your standard places. Cannot right. What are the risk factors? So you randomly picked up 3-4 numbers, names. So you're
Yes.
to classify answer as the risk factors. General risk factors: male, age, history of smoking, pregnancy, associated medical condition like obesity, hypertension, diabetes, chronic nasal congestion, asthma. OSA is not just obesity. You have to understand OSA is more than obesity. Obesity is just one of the cause of OSA. Okay.
Yes, ma'am.
Physical examination of the airway: if neck circumference is high, if there is retrognathia, if the narrow upper jaw, there is enlarged tonsils, Down syndrome, bulbar palsy. Central causes can be a neurological insult or a sedative agents like benzodiazepines and alcohol. Here it will come up Duchenne's muscular dystrophy. Right?
Yes, ma'am.
Diagnosis: top bank questionnaire and apnea hypopnea index were whatever you mentioned was right. At times they do ask what all you see in your polysomnography apart your hemodynamic saturation. Then you look for apnea hypopnea index. Okay. Yeah. Then it comes to the operative assessment. So when we talk about assessment, generally we classify as history, physical examination, and investigation. In history, well, if it's related to obesity, and I gave the scenario, the BMI was too high. So you need to talk about the cardiovascular system or the other system that is involved in obesity. Okay.
Yes, ma'am.
Hypertension, heart disease, hypocholesterolemia, arrhythmias, heart failure. If you come to respi, core pulmonary, and CNS cerebrovascular disease will be there. If you go to metabolic syndrome, insulin resistance, history of PRD. Right. So
Yeah.
coming to examination, obviously you tend to see all the, if there is a, because core pulmonary is there, so you have to see the features of right ventricular failure. Okay. And
Okay.
error. Then when it comes to investigation, you need to look for the full blood count, especially for polycythemia, because there is an underlying long-term hypoxia that can be there. Urea creatinine, if the patient is hypertensive, there can be renal, or a diabetic can be renal impairment that can result CKD kind of features. Liver function for hepatic congestion as well as NASH, non-alcoholic steatohepatitis. Go for blood glucose ECGs. So this is what is called as the structured approach.
Okay.
Okay.
Yes,
So
ma'am.
you need to talk all this thing in the pre-operatively. You didn't mention any time about the CPAP or BiPAP. So when the AHI is more than 15% or the pulse ox reads less than 94%, you need to put the patient on bilevel BiPAP or CPAP pre-operatively and ask them to get it on the day of the OT. Okay?
Yes, ma'am.
Yeah. Then intraoperative, as I mentioned, even one of the scoring used is a POSUM scoring. And then I will actually there are
Yeah.
two things that are given according to the SOBA guideline. What is the what has to be followed, like weight-based calculation. Okay.
Okay.
One change is there between in BG article and this article. I think about one of the drug is different. Rest all is same. So you need to know there are three weights: lean body weight, adjusted body weight, and actual body weight. As you correctly mentioned, succinylcholine is a water-soluble drug, so it has to be given with total body weight. Rest, most of the anesthetic drug are given with lean body weight. The reversal agents or the low molecular weight heparin, I think in the other article, low molecular weight heparin, they have written with actual body. It will come to that, right? So
Yes,
you
ma'am.
need what are the definition of three body weights and what are the drugs which is given according to.
Okay.
Okay.
Mm.
Then the other article, are you able to see my screen? Which
Yes, ma'am.
article for you? Yeah. Which screen? Are you seeing my entire screen, right?
Yes, ma'am.
So NICE has come up with the guideline, the indication for bariatric surgery. So one of the one which you mentioned, BMI of more than 40 or between 35 to 40. Okay? If the patient is having a type 2 or high blood pressure. When there is a failure of medical therapy.
Okay.
Right? The patient who is in ICU means because of obesity, like they are in a higher need. So those are the few indication, and assessment for bariatric surgery should be considered in a patient between 30 to 45 or people of Asian family at a lower BMI who has recent onset type 2 diabetes. So this is given by NICE. Even if you first tell 2-3 points also is fine, but you should be aware that that's a NICE guideline which has come up with the indication for bariatric surgery.
Okay,
Then I
ma'am.
asked about liraglutide. Liraglutide is a GLP-1 receptor. If you go through our last session was on endocrine, which is very, very important. There we have discussed in detail about the classification of the drug. What is the updated one? I'm sure what you know about diabetes is all the older versions. Now every 2023, 24, 25, everything is updated. Need to go through our recording on the endocrine, where very clearly I have taught and I've given the sources also from where you need to learn the new thing, because the question examiner have shifted to the newer ones. And the biggest problem with liraglutide is liraglutide and your semaglutide, these drugs, the GLP-1 receptor agonist, they are responsible for delayed in gastric emptying. So the patient will land up in gastric aspiration. So there are 10 NCP clinical practice guidelines that has come up. How do you manage a patient who's on liraglutide? Generally, the drug has to be stopped 39 hours prior to surgery. And if the patient is on semaglutide, it has to be stopped at least 20 to 21 days based on oral or IV before surgery. The patient need to be on a liquid diet 1 day before surgery. The gastric focus has a role to be done, and the patient should be considered as a full stomach, and there are few other recommendation that has to be followed. So this is an update which you need to go better with.
Okay, ma'am.
Preoperatively, there is something called as the obesity surgery mortality risk score. Okay. So this I already discussed. Yeah, low molecular weight heparin. Here they are given with total body weight, and in the other article they have put it here. So I think that much is not like it's not that kind of controversy. Like they will pick you on a single point. At least saxamethonium, propofol, important things you need to know. Then I asked you about during surgery. Okay. No, that will come late. So, what are the different position? Ramp position, use of polio blade, use of fiber optic. Okay, performing, having the senior most trained anesthetic, having a ABC approach, care management. Okay, if A fails, what B won't see. And if you're using rocuronium, always have Sugammadex on standby. Then what are the implication if the patient has obesity? So obviously the risk of aspiration will be difficult. There will be high risk of losing the airway, like airway management is one issue. Because of the obesity, even the VQ mismatch, whatever you mentioned, so you have to follow a reverse Trendelenburg position. If you think that will be intra arterial invasive arterial monitoring is also very important because the blood cuff and all. So whatever you learn about the SOBA guideline, what is the management of obesity, everything has to be incorporated in this answer. So very good answer that Dr. Nupur gave. In such patient, there is a role of HFOV, high frequency nasal cannula, means, high frequency nasal oxygenation, HFNO. Okay.
Yes,
So
ma'am.
that is one of the indication that you do the pre-oxygenation or para-oxygenation while you're trying to secure the airway. So this we already discussed. Then I asked you about the ventilation strategy. So lung protective is overall same, but you have to talk what is the tidal volume, what is the PEEP you are expecting, because there will be pneumoperitoneum as well. So the peak airway pressure can be high, so your target should be less than 30. So even if you know the answer, you have to vocalize.
Okay.
So anesthesia, analgesia, I didn't ask though. They can ask you about what are the drugs because like regional anesthesia has role over here. Okay. Antiemetic prophylaxis is recommended as nausea vomiting is highly undesirable. Then I asked you, so this is not very important, but at least you should know what are the type of surgery. Especially why you should know is Rowan and why is associated with maximum risk of dumping syndrome, which I asked you. Okay.
Yes.
Post-operative care, nausea, vomiting, thromboembolism you mentioned. Anastomotic leak is something you should not forget. This is very common and the most feared complication of bariatric surgery. Especially who has BMI of more than 50 and with metabolic syndrome. Okay. Then I asked you about bleeding, post-operative complication, nutritional deficiency, vitamin B12 deficiency happens because it is absorbed from the large intestine, no? So they cut it when and why. So there will be a vitamin D. Prolonged cases, there will be a megaloblastic anemia. Then comes the dumping syndrome. What happens in dumping syndrome? Initial phase and late phase happen. Initial phase, early phase happens within few minutes to us. Here there will be abdominal pain, nausea, vomiting, flushing, diarrhea. Late phase, it happens 1 to 2 hours before and after. And there will be increase in insulin secretion resulting in hypoglycemia. Okay? At
Okay.
least this you need to know. Yeah. Rest, trial and all, if you want a score of 80 out of 80, maybe. Okay. Then ERAS. So in ERAS here, what all, so ERAS is now what has happened, every society has come up with a specific ERAS for each of the surgery. Okay. Like ERAS for abdominal surgery, ERAS for intestinal surgery, colonic surgery, everything has ERAS now. If few things which ERAS after bariatric surgery has come up is preoperative carbohydrate loading you have to do to reduce catabolism. Go for a opioid sparing multimodal analgesia, which has come up for most of the studies. Early ambulation and oral intake post surgery because they want to remove all the drains and lines. And you have to minimize the fasting and go for early enteral nutrition.
Okay.
Yeah. Any question from your side?
No, ma'am, it's clear. Okay.
You look like a very hardworking girl. I think you should be fine, but I really want you to work very hard now. Whatever you are preparing, it has to come.
Okay, ma'am. Thank you.
Any doubt from any one of you on this topic?
No, ma'am.
Any doubt or should we move to next?
No, ma'am, I'm clear. Okay.
Anyone
Ma'am, I
else?
just wanted to ask, like for ERAS, just knowing the basics and we should just, like, that's what I do, applying it for every surgery because obviously I can't read for all the
You
surgeries
cannot remember.
separately.
You and I don't remember. So just remember, these are few, actually, ERAS has come up with 21 points. Okay.
Mm.
And they validated 14 points for pediatric patient. Right. So if you read the ERAS, there are few things that has to be done in pre-op, few things in the intra-op and few things in the post-op.
Yes, ma'am.
Pre-op, actually, in my other laptop, I had that presentation. Presented on an international conference. Just let me see if I have. Just give me 1 second. So you take a photo of like a snapshot. I think that presentation is huge. I cannot share my presentation. So I will just show you, take a photo of the same, and I think if you just, whatever maximum you can remember, if you talk, that is more than sufficient.
Okay, ma'am.
Okay. Can you see my screen? Just take this photo. So this is sufficient. So these are the things which has to be done in pre-op, things which has to do in intro, and things which has to do in post-op.
Thank you, ma'am.
For any surgery, you tell, see, there are just few, like in pediatric, what has happened out of this, they have, this is what I was telling you, 14 points out of the 21 points they have removed. So, see, like, so if you see, they have removed, they in the final pediatric errors, they have included this point. But basic is this, because from the adult, everything is derived. Now they are just picking 1 point, removing 1 point, playing 1 point, and they're making a surgery specific. So that is actually not possible. Even I don't remember, then how can I expect you will remember? So you at least remember this 21 points. Even if you speak some 10 to 10, 12 points also, it is fine. At least they will be sure that you know the stuff. That is what is expected. This is also you can pick up. If you think the other one was not that nice, you can take this snap. At least just adult eras you remember. Pediatric is not needed at all.
Okay. Thank you, ma'am.
Fine. So who is coming up for the next?
I'll come up next, ma'am.
Okay. Dr. Nupur told, no?
Yes, ma'am.
So you have a 65-year-old male with a history of colorectal cancer and hepatic metastasis is scheduled for right hepatectomy. His BMI is 32 kg per meter square with a history of type 2 diabetes mellitus and underwent neoadjuvant chemotherapy 5 weeks ago. Pre-operative assessment shows a hemoglobin of 11.2, bilirubin of 1.8, albumin of 3.2, INR of 1.3. Am I clear? Or you want me to put the question in chat box?
Yes, ma'am. Can you please put the question in the chat box?
Yeah.
Sorry, ma'am. I'm just noting down the question. Mm, okay. Yes, ma'am. Yeah, yes, ma'am. So, yes, what is my starting question, ma'am?
This is your starting question, whatever I asked
Okay.
you. Should I ask the question now?
Yes, ma'am.
Right. So, just give me 1 second. That Have you read this article? You also know what I'm referring to. If you have read,
Ma'am,
then
I
you can,
read this long time back, hepatic resection.
then it is good for me. Because else if you answer everything, no, there is nothing left for feedback. So easy for me but anyways, we'll test it. Fine. So can you tell me how do you preoperatively assess this patient?
Preoperative assessment would be history, first of all, history taking. What are the symptoms? Because he's got a primary of colorectal cancer and with hepatic metastasis. So, what symptoms does he have? And he's already had neoadjuvant chemotherapy 5 weeks ago. So, if he's got any, what was the chemotherapy he received? And if he's got any symptoms related to the chemotherapy or not? Uh, Adjuvant symptoms. Then comorbidities. So he's type 1 obesity because his BMI is 32 kilograms per meter square. So associated problems with obesity, if he's got any OSA, history of snoring. He's not mentioned, but if he's got any history of hypertension, he's got type 2 diabetics, what are the drugs he's taking for his diabetes? What is his diabetes control? What was his last HbA1c level? Mm,
Why your voice is tapering today, Dr. Nupur? Have a steady voice.
Yes, ma'am. Apart from this, then uh, try to figure out, they will try to assess what, if they want to do right hepatectomy, what, how much of the liver they want to remove. So that will be done
So can you tell
preoperative.
me how much the surgery should be delayed if the patient is having chemotherapy? Like last
Uh,
chemotherapy and surgery, what is the gap?
at least 4 to 6 weeks, it
Mhm.
should be delayed.
What are the preoperative liver function tests you know?
So preoperative liver function test would be the bilirubin levels,
Mhm.
the ALT, AST, ALP, GGT levels, then albumin, serum albumin, serum total protein with serum albumin and globulin, and the albumin globulin ratio. Then functions of coagulation function tests like prothrombin time, activated partial thromboplastin time, international normalized INR or international normalized ratio.
Fine. So the patient has come to you and you wish to assess for the post-hepatectomy liver failure if it happens. What are the various scoring or the test you know
So
to
for
find?
chronic for liver disease, there are mainly two broad scorings. One is the child perk scoring, which is divided into three classes: A, B, and C. A is the least severe, B is moderate, and C is most severe. And the other one is the MELD scoring, or the model for end stage liver disease, which is less than five. Uh, which is less than 5, 5 to 10, and 10 to 15. So less than 5 is mild risk, 5 to 10 is moderate risk, and 10 to 15 is higher risk. And in child pox scoring, the five variables are assessed: albumin, INR, bilirubin, encephalopathy. I can't recall the last one. There's five variables. And MELD scoring is INR, albumin, and bilirubin. And there's another one called MELD sodium as well, where they assess the sodium level for hyponatremia.
Okay. Anything else? Have you heard about the term FLR?
Yes, ma'am. FLR is for hepatic resections, for hepatectomies, uh, future liver remnants. So, how much of the viable liver will be there enough for the functioning of the liver? If they remove the liver, how much will be remaining for the safe volume of the patient? So normally it is 20% is a normal value, which should be at least safe for the patient to have after the surgery.
For this patient, do you think if there is 20% remains, then it is fine? For the
So
case I have
20% is for normal liver, and it is 30 to 40% with patients who have had chemotherapy and patients who had some alcoholic hepatitis, and for 50% for patient with cirrhosis because their liver is obviously not at the normal physiological reserve.
very good. What are the other estimation?
CT and MRI estimation can be CT and MRI is used for
Any
this.
dye, dye estimation study?
Indocyanine green is used.
What is the
Indocyanine.
minimum need? Then so
Mm,
what do you call it as the impaired testing, impaired clearance?
I cannot recall, ma'am. I did read, but I cannot
This
recall the number.
patient had a FLR of 50%, right? So you're not ready to take off for the surgery. So do you know how do you augment the FLR?
Yes, ma'am. They can do certain surgical techniques like embolization of the portal vein, then ligation of the portal vein, and there's a term called as ALPSS, which is like a staged hepatectomy.
What else you know? So you mentioned about portal vein embolization, portal vein ligation, right? And your APPS. Anything else? So when do they do a ALPPS? Any specific indication?
When it's a two-stage procedure, which is done for if the patients have inadequate future liver remnant, and it is done for if portal venous embolization has failed, and when obviously starting FLR is low, and when the tumor is very close to the uh, future liver remnant.
Okay. What are the intraoperative concerns you have?
So the intraoperative concerns would be the patient, the problems related to the inherent disease status of the patient, because the patient has got a cancer, colorectal cancer with hepatic metastasis. So liver functions will be affected. He's type 1 obesity, diabetes, then he's received chemotherapy. So problems related to that. And then problems
Now,
related to the
Dr. Nupur, you need to be loud. Like you either come to the mic or you go towards the mic. And so you make the mic comes to you or you go towards the mic. Anyone will do. Your voice is
sorry,
kind
ma'am.
of happy each time.
Can you hear me properly, ma'am?
It's better now.
No. Sorry, I think yes.
Oh, and
Uh,
nothing to be. I want you to have the because you're answering, I'm listening, no? So your voice has to be constant voice.
So problems related to the inherent disease status of the patient and the problems related to the surgical aspects, which is hepatic resection, will cause fluid shift in the patient. So adequate maintenance of adequate hemodynamic status is important. So these will be the intraoperative concerns, and maintaining. So when they're doing the hepatic resection, we'll have to minimize the hepatic blood loss while at the same time maintain the end organ perfusion.
Hmm.
Mode of anesthesia would be general anesthesia. My choice would be total intravenous anesthesia with TCI, propofol, and remifentanil. Uh, for analgesia, I'll go for
Would you like to go for any cardiac output monitoring intraoperatively?
yes, ma'am. I'll go
Why?
for
How it depends. Like for every patient you do, or there are any specific indications?
this patient is type 1 obesity with diabetes, and he's received chemotherapy. There might be certain hemodynamic changes. There can be manipulation also. So I'll go for cardiac output monitoring. And then I'll go for arterial line monitoring and cardiac output monitoring also for this patient.
Okay. What are the various analgesic option you have?
So analgesic, I'll go for multimodal analgesic options are there. So it can be divided into oral and systemic analgesics and regional and local anesthesia techniques. So systemic analgesics can be paracetamol can be given if the liver functions are normal with a safe dose. NSAIDs, if the renal functions are normal, then others would be like IV opioids like morphine, oxycodone, short term like fentanyl can be given. Then magnesium, ketamine, lidocaine infusion. Loco-regional techniques would be wound infiltration, local infiltration of the wound, then thoracic epidural, but thoracic epidurals, the popularity is decreasing now. It's being overtaken by truncal blocks like tap blocks and rectus sheath blocks. And intrathecal morphine is also an option, and wound catheters can also be inserted. Then erector spiny block can also be given.
So intraoperatively, the surgeon asks you to do certain maneuvers so that the blood, because the bleeding is happening too much. What are the various maneuvers which you can do? Maneuvers or management you can do?
So the bleeding has to be low, so various.
Yeah.
I can give reduce the central venous pressure. I can give a diuretic like furosemide. Then I can use glycerol GTN infusion. Then I'm using remifentanil, which will also reduce the CVP and the blood pressure. Then uh, avoid PEEP and fluid, avoid of PEEP. Then fluid restriction
Mhm.
and put the patient in Trenden-Lindbergh position.
Mhm.
So these
Any other
sorry.
thing? Mhm. Okay. Are you any other drug I mean, any pharmacotherapy, which can be given?
Mm, no, ma'am, no, I cannot recall.
Okay. Any surgical technique, which can be used to minimize bleeding?
So surgical technique which they use is called as they use CUSA, which uses ultrasonic energy to for tissue dissection. So that helps in their dissection, and it is supposed to be better than the other things which they use as hemostatic agents like
Have you
flow
heard about
seal.
maneuver?
Sorry.
Have you heard about Pringle maneuver?
Yes, Pringle maneuver is when they clamp the hepatoduodenal artery to stop the blood flow to the hepatic artery and the portal vein. This decreases the venous return, and this can be utilized by the surgeon at the time to
Very
reduce
good.
the CVP and the blood flow.
Okay. So what will happen if they continuously keep it clamped? How much time you will allow them to clamp?
So it's usually in normal liver it is 1 hour, and it is 30 minutes if it is a diseased liver. If the clamp times are increased, then it can cause because the hepatoduodenal artery is obstructed, then it will cause reduced blood flow to the mesentery and the gut. So it will cause ischemia, ischemic mesenteritis or ischemia of the gut. So
What is the
usually
error
it is
particle section surgery?
the eras for hepatic resection surgery can be divided into preoperative, intraoperative, and postoperative criteria. So preoperative, first of all, would be counseling of the patient and education of the patient about the surgery. what will be the surgery. If the patient is high BMI, diabetes control of the patient, then BMI to help them mobilization of the patient and active exercise of the patient as much as possible because it will be an abdominal surgery. The FRC will be reduced later on, so incentive preoperative incentive spirometry will help them optimize. Then minimize the fasting time of the patient. So it's 2 hours for liquids. The patients can have liquids, sips of water even before the
Okay.
surgery.
Dr. Nupur, we'll stop you here. How you felt about yourself?
I'm all right because I don't do this very commonly, and I read this article
When you had
some
read?
time back. I thought because we shifted the things, so I read it 2 weeks back when I thought actually liver GIT date was 2 or 3 weeks back because at that time I thought initially that was the liver GIT date, and then we shifted it to obstetrics that week.
Yeah, that time we had some faculty issues like availability issues, so I had to reshuffle. Anyways, Dr. Nupur, I would say your knowledge is quite good and your memory is even more than what can happen. So you're one of the very, it's not just because I just have to say something, but you're very bright. And so I think you have done your FRC part one, no?
I have done my part one.
But I would say the level of knowledge and memory, what you have now, you go forward for FRC as early as possible. You will definitely make it out in first go. EDAIC is now less for you. You can actually finish EDAIC, FCI and FRC together.
Ma'am, I plan to actually I was not getting a slot for the OSCE. I had prepared for my OSCE and then twice I was late in applying.
Why don't you write FCI?
Yes, ma'am, that I intend to do so, like after I do this EDAC.
Immediately, like I think they have one slot in July now. FCI part 1 and part 2.
Okay.
To finish it off. Don't, because as per your current level, no, it will be very easy for you. But else, if you, because your memory is good, at least what I can see, if you remember, if you have read this article 3 weeks back and now you are telling exactly the so like everything so perfectly, I think now you are in your best form. So you finish it off whatever maximum you can do with this knowledge. Like at least for exam.
Yes, ma'am.
But you're seriously, it's nothing to actually. You have entirely spoke everything. Whatever I had to ask and tell. Like Dr. Sara, this is your first time. Can you differentiate the difference? Can you see the difference?
Yes, ma'am.
Sarah?
Yeah.
Yeah. So everything she told is answering is so structured. And if I show you the article from which I framed the question, you will understand how clear and clarity her answering is. She is
Yes.
example. You want to be like
Okay,
this.
ma'am.
So you
Hmm.
that's all. Rest Nupur, one important feedback is your voice is not constant. I thought initially it's a technical issue, but what I feel no in the process of answering, gradually your voice is being heard as a murmuring, like you are trying to answer yourself. It's not very clear.
Okay, ma'am. I'll try to maintain a constant level.
Means because I initially I felt it's a technical, but I remember last time also I gave you the same problem. Like in the process of answering, no, gradually your that pitch is going down. You are trying to answer fast or something like which you only can understand, because in EDAIC exam what exactly happened with me way back though, I got a case of DKA. They've asked me about the electrolyte abnormalities. I clearly told about hypokalemia, your phosphatemia, hyponatremia. When it came to phosphate, I already mentioned is hypophosphatemia, but I was a bit fast because I knew the answer. I was talking fast. So the examiner could not listen at hypophosphatemia because she was, I think, from Italy or something. Her English was not that great. She again asked me, or she was heard of hearing, I'm not sure. She again asked me, I again answered. Because it was a provoked. When she asked me, then I answered is what she assumed. She cut my 1 mark. So I could not get the full mark in a DIC. So because you are doing so good, that's why I'm saying I want you to score full. That's not,
Thank you,
not
ma'am.
the
You have really high expectations of me.
I'm not,
Yes,
I don't want to tell you, like, it's, what I can see is you will definitely get. I am not sure about your basic sciences, and I have input from Dr. Dikshita that you are struggling a bit in RA. So I cannot say on things which I have not examined, but on the topics which I have examined, you are doing good. So you should definitely get more than 70, but these are finer things which can reduce your scores. So you have to
yes,
focus.
ma'am. I'll make sure. Yes, ma'am.
Yeah. So even the politeness you are maintaining is good, but that fluctuation is too much, because I 3 times I had to pick you up, that be loud, be constant. So that is something you have to work on it now. Purposefully you try to do it.
Yes,
Okay.
ma'am.
So this was the article of 2022 from where I had framed this question, perioperative management of hepatic resection surgery. So initially I asked her about the preoperative assessment. She mentioned about the comorbidities, about chemotherapy. So again, neoadjuvant chemotherapy will reduce the tumor site and facilitate the surgery. However, they have their own complication, especially they are mostly the cardiotoxics. Okay. So if the patient is on chemotherapy, the surgery should be delayed 4 to 6 weeks after completion of treatment. If is amount of lung will be able to work at the entire lung. So we see if the patient is capable of or pneumonia or a particular segment section. Similar thing is done for liver. So we have brings the melt. I'm so sorry, actually some internet issues is there from my end. So how far you had heard?
Ma'am, you were explaining about the chemotherapy, when to delay surgery if the patient is on chemotherapy.
Fine. So chemotherapy, after that, I was asking her about the liver dysfunction. So in pneumonectomy, like you do a three-legged approach to see what is the level you can allow the surgeon to do, whether the patient can go for a lobectomy or the patient can go for a pneumonectomy or a selective resection. Similar thing is done for a liver. Preoperatively, you assess what is the minimum amount of liver that has to be left so that it will function post-operatively and there will be less chances of post-hepatectomy liver failure. So one scoring is the child book scoring. What is this ABC? You mentioned the points. I think PT and prothrombin time is the one which you could not, I think you didn't know.
Yes, ma'am. I think I missed one. There are five. I
That's
remembered
fine.
four.
Remember it as EPAP. So E stands for encephalopathy, P stands for bilirubin, A stands for ascites, A stands for albumin, and P stands for prothrombin.
Thank you, ma'am.
Okay. Second is MELD, also 10 to 15 you told correctly. So this is one of the interesting thing which is new for most of you, the volumetric assessment using CT MRI where they look for the future liver remnant. So if it is a normal liver, if you resect 80% and leave only 20%, 20% is sufficient enough to take care of the So second comes your patient who has severe steatohepatitis or receiving chemotherapy, at least 30 to 40% of the liver has to be left. And if the patient has cirrhosis, at least 50%. So for this patient, it was 30 to 40 because the patient was on hepatotoxic chemotherapy. Second, other thing is the estimation of the functional reserve using indocyanine green. So if you give an indocyanine green as that is to do for the dynamic hepatic function and calculate the minimum volume. Again, the impaired clearance of ICG is suggested when more than 50% of the dose remains in the plasma 15 minutes after injection. So you just remember both are 15.
Yes, ma'am.
Then augmentation of FLR. So one is portal vein embolization, second is portal vein ligation, third is ALMS, where they do a liver partition and portal vein ligation for staged hepatectomy. And finally is the liver venous deprivation. So when the liver venous deprivation is failed or the patient starting FLR is very low, tumor margin is close to the one you wish to resect, then you go for a ALPS. Intraoperative consideration, whatever you mentioned was right, but here there is a need of cardiac output monitoring and just not IVC line, because you need to have a fluid and goal-directed fluid therapy. Intraoperative, lots of hemodynamic changes will happen, so you need a cardiac output monitor. Okay. Then analgesia, you mentioned about thoracic epidural, you mentioned about the common, and you classified the answer. That was again good. I didn't hear you. Did you mention about intrathecal morphine?
Yes, ma'am, I said intrathecal morphine.
So rest everything you had mentioned, so nothing to add. Then comes intraoperatively, how do you reduce? So one is the CVP target should be kept low. You have to restrict the fluid. You have to give diuretics. Okay, keep the patient in Trendelenburg position. Avoid giving excessive of PEEP. And then tranexamic acid and vitamin K are the medical management. Surgery, one is CUSA device which use, it's not ultrasound, it is the ultrasonic energy. Like you do your ERCP, no? Use the ultrasonic
Yes,
energy,
ma'am.
break or the fragment the thing and aspirate the final particles. That is how that CUSA work. Okay. Then there are, you use like argon beam coagulator, use bipolar electrosurgical method, electrosonic scalpels, and thunderbeat. These are the things which will minimize the bleeding or improve the surgical techniques. And finally, the Pringle maneuver. As you correctly mentioned, it is the clamping the hepatoduodenal ligament to interrupt the blood flow to both artery and the portal vein. But if it has to be restricted to 1 hour for normal liver and 30 minutes for pathological liver. Because if you do more than that, the blood circulation to the liver will be hampered and it will result in ischemic perfusion injury. So you have to go for intermittent control. Other one is a total vascular exclusion in which all the blood flow to the liver is stopped. Okay. And finally, ERAS, as we discussed in the last question, similar thing, preoperative counseling, nutrition, minimize fasting, carbohydrate loading, oral bowel preparation, similar points. So I picked up because we had discussed in the last question itself. So I didn't encourage, like I stopped you here. Fine.
Yes, ma'am.
Yeah. So you have anything to ask me now? Any question?
No, ma'am. Thank you.
Anyone else has any doubt in this question? Fine. So who is coming up for the next one? You might get repetition as well because we have many to cover. So I'm not sure um, how many multiple times each of you have to come, but we have to come because we have to finish it off. Yeah. Who is coming up for the next one?
Ma'am, can
May
I?
I? Okay.
Yeah. Can I? Anu? Who all asked? Anu and Aditya?
Yes, ma'am.
Okay. We'll take up Anu at least one round, let them finish. Then we'll start a repetition round. Right? Yeah. So, fine. So, a 58-year-old male with alcohol-related cirrhosis and portal hypertension is admitted with refractory ascites and recurrent variceal bleeding despite beta blockers and band ligation. Okay.
Okay,
So
ma'am.
now decision has been made to proceed with TIPS insertion to control portal hypertension. So can you tell me what is the blood supply of the liver?
Uh, Blood supply is mainly by hepatic artery and portal vein. 20% is by hepatic artery and 80% is supplied by portal vein. And it is almost around 25% of cardiac output. And then after venous drainage is by left, right, and middle hepatic veins, which drains into IVC.
Drains into?
Inferior vena cava.
Okay. And how portal vein is formed?
Portal vein is from splenic vein and superior mesenteric vein combined to form portal vein, while hepatic artery is a branch of celiac artery.
Okay. So how do you define portal hypertension?
Portal hypertension occurs when there is a distortion of architecture of the liver, resulting in increased venous pressure. Like if it is normal pressure is 5 mm mercury, and if it is more than 10, it is defined as portal hypertension.
So what do you want to see? Which pressure you wish to see?
It is a portal vein pressure.
Mm-hmm. So what is the normal? Have you heard about the term hepatic venous pressure gradient?
Hepatic venous pressure gradient. There is hepatic arterial buffer, not that, right? No.
No.
Yeah, the gradient between the hepatic and the portal vein, hepatic artery and the portal vein. I'm not sure.
So how do you define the portal hypertension based on the gradient?
Like mild, moderate, severe, you're asking? Is there any? I'm not sure.
Okay, no issues. So can you tell me what are the clinical features in a patient with alcohol liver disease?
The alcoholic liver disease, alcohol is one of the most common cause of a chronic liver disease. So they will have uh, uh, like they have symptoms in all the it is a multi-system dysfunction. So clinical features are mainly from head to toe. If you examine, they can have first of all in CNS they can have hepatic encephalopathy and symptoms associated with that. Then there will be parotid enlargement in the chest. There will be skin manifestations as spider navy, dupuytren's contractures, thin friable skin, um, palmar erythema, and then they will have a cardiovascular system. In a case of chronic liver disease, it has a high output, like they will have a reduced systemic vascular resistance, and then they will be having splanchnic vasodilatation. So they will their systemic blood volume will be low. Then coming to pulmonary system, they have they have hydrothorax. Then because of ascites, their FRC, everything will be low. Atelectasis can happen. Then there is a hepatopulmonary syndrome and portopulmonary hypertension associated with CLD. Then in GIT, again ascites. They can have spontaneous bacterial peritonitis. They have a delayed gastric emptying because of the ascites and gastroparesis. Then in renal system, their renal perfusion is also impaired. Because of that, they get a hepatorenal syndrome. And also they may be taking diuretics and all, so they may have electrolyte imbalance associated.
Hmm.
And they also they
What's the indication for tips in this patient?
most common indication is refractory ascites and variceal bleeding. So this patient is having recurrent variceal hemorrhage. So that is one indication for doing tips. It's a palliate like bridging procedure.
So any number of MELD, above which tips is indicated?
MEL score more than
What is the contraindication to tips?
tips is a intervention procedure. So if any cases of severe coagulopathy or if in tips they cannulate the jugular vein. So if there is any right heart dysfunction, it is contraindicated, like any severe pulmonary hypertension or tricuspid regurgitation, it is contraindicated.
Okay. Can you tell me few causes of portal hypertension?
Portal hypertension can be prehepatic, hepatic, and post-hepatic. So it can be a thrombosis of in prehepatic splenic and splenic vein thrombosis or superior mesenteric. Sorry, yeah, splenic vein and superior mesenteric vein thrombosis. And then in hepatic, it can be any cause of cirrhosis, like viral hepatitis, alcoholic hepatitis, or Wilson's disease. Uh, then any drug-induced cirrhosis. And in post-hepatic, when if IVC, when there is Buchiari syndrome, or when there is any IVC thrombus, which can result in it can result in post. This is a post hepatic cause of.
Okay. So how do you do the pre-operative assessment for the case?
Ma'am, can you put that case in chat box? It was patient with ascites and varicose hemorrhage, right? So in pre-op evaluation, we have to first ask history, like since when he is diagnosed with chronic liver disease, and what is the probable etiology. Here it is given as alcoholic. So and then we have to see the associated comorbidities, whether he is diabetic, hypertension, and any other thing. And also we have to rule out any other extrahepatic manifestation which we have described now is there. So we have to carefully examine all the systems. Then we have to find the functional status of the patient. How is the effort tolerance? Then airway has to be examined, and airway system examination, and then we have to do the relevant investigations. So here we have to do CBC. We have to do all the routine investigations: CBC, electrolytes, RFT, liver function test, INR, uh, all the blood coagulation parameters, PT, INR, APTT. And as it is a chronic liver disease, it's better to do a rotam or TEC. Then we have to see for
Cutoff, what is the cutoff for platelet and INR to do tips, or with any platelet, any INR you can proceed?
no, ma'am. Platelet count should be at least more than 50,000, and INR should be more than it should be less than 1.7.
Okay. What else test you wish to do? What apart from whatever you mentioned?
ECG, chest X-ray, echo, as the patient may have a
Any
right heart dysfunction. Sorry, ma'am.
Any blood investigations?
Blood investigation. Blood glucose has to be checked because they are more prone for hypoglycemia.
So what is the plan of anesthesia?
Plan will be general anesthesia with a rapid sequence induction because he
So can
has
you
recurrent.
do a sedation? Can you go for a conscious sedation?
Because the patient is having recurrent hemoptysis and all, it is better to secure his airway, as he has and he's a non-case of CLD, so he has more chance of aspiration. So I'll better go with general anesthesia and with endotracheal intubation.
Okay.
Then
Tell me,
and
what are the advantage of GA over, like one point you mentioned? Any other important advantage of GA here? So by the way, TIPS is performed where?
it's a NORA procedure, ma'am. It's usually in DSSU.
So
So advantage is that in if it is in sedation, the recovery will be faster. The it's a advantage. 1 second, ma'am. You're asking advantages of like compare the both, right?
I'm putting a question like a pro-con. Like you have to
Okay.
tell me, you're choosing GA, why GA? If you are choosing sedation, why sedation? What has the advantage of one over the other? Put it as a debate question.
So in general anesthesia, as it as the we have a better control over hemodynamics because in a chronic liver disease, the drug metabolism is will be altered. So. If we are giving a conscious sedation or TIVA, we'll have to go for a very titrated doses because there and we will because
What are the challenges for a TIPS insertion?
sorry, ma'am. How?
Anesthetic challenges for a TIPS insertion.
Okay. So first is NORA concerns. So it's a non-operating room anesthesia, and the head end will be not available to us because they are inserting it through the jugulars. If any airway compromise occur and if we are not secured the airway, then it will be difficult to difficult in managing the airway. Then radiation hazard is there. Then
Okay.
then non-familiar environment.
So what happened? You are doing the case and suddenly intraoperatively you see this ECG. Can you read the ECG and tell me what happened?
Here there are there are flutter waves in ECG. But hemodynamically patient is stable, ma'am.
Means blood pressure is going to put down now. So
Okay.
what is the reason why suddenly the rhythm changed?
It may be due to the right heart, like they are putting cannulas, guide wire through right heart. So maybe it must have irritated the
So how do you
atrium.
manage?
So we can tell the surgeon to stop the procedure, withdraw the guide wire, and see whether it is improving. And uh, and then simultaneously we will have to see our ABC. We have to do the ABCD approach. So we have to look whether there is
Patient is
hemodynamic compromise.
hemodynamically unstable. So how do you manage?
Okay. Then, as if our airway is already secured, then we'll have to do with we have to check for we have to auscultate and see bilaterally, and we have to see for the blood pressure. If there is low BP, then even after the surgeon is removed, if it is not improving, we'll have to give fluids, and then we will have to start a antiarrhythmic.
So, Dr. Anu, the question is patient is in atrial flutter with unstable hemodynamics. What do you do?
Uh, so first we'll have to give we'll have to remove the mechanical cause, and once it is removed, we'll have to give amiodarone 150 mg bolus followed by infusion.
Patient is hemodynamically unstable. What do you give? Okay. What are the major post-operative complication of TIPS?
Post operatively, the patient can go into they can have hepatic encephalopathy.
Grade hepatic encephalopathy.
It's graded into four. Grade one is the patient is having less attentive attention and irrelevant talk, and there is difficulty in doing mathematic calculation. Grade two is there is mild disorientation of time, place, and person. Grade three is gross disorientation of time, disorientation and drowsy. And grade four is completely comatose patient.
Okay. So, how do you manage hepatic encephalopathy post-TIPS?
While managing encephalopathy, first we have to see what precipitated this. So here maybe the TIPS procedure. So then we will have to do supportive management, like we will have to depending upon the grade of encephalopathy. If it is grade 3, grade 4, we will have to secure the airway. Then we will have to uh, uh, we will have to give we will have to start antibiotics like neomycin to reduce the gut bacteria, so that the ammonia production is reduced.
Which drug you mentioned?
I don't know, ma'am. I think it is any gram negative neomycin.
Okay. We'll stop you
Yeah.
here. How do you find the proposal, Dr. Anu?
I don't know, ma'am. I read the topic, but I'm not able to articulate again. That's my problem.
The point is you have read the topic is what I could also pick up. But I would say if I compare what you answered to the article, you could replicate almost 60 to 70%. Okay. But 30% you
Yes,
could not
ma'am.
replicate. You could not give that. But what actually the problem what I felt is when I just read to a case of arterial flutter with unstable hemodynamics. Now because the Viva is over, now I'm again asking, can you just think what is done in a patient who is unstable?
So here we will do the ABCD approach, ma'am. We will call
That
senior.
is
We will.
done. That is what you mentioned about plus you mentioned about airway, you mentioned about B. Just focus on C. Patient with
Okay.
arrhythmias, stable, unstable. What is
Yeah,
done
it
if
is.
it is
Yeah, ma'am.
unstable?
Yeah, if cardioversion has to be done if it is unstable.
And you know, I asked you thrice.
Yes. Yeah.
I asked you thrice. Every time you came up with antiarrhythmic.
Mm-hmm.
If there are two tips, you will be a pass. But so
Ma'am, your voice
answering,
is
you
breaking.
have to come out of. Now my voice is breaking. Am I better
No,
now?
ma'am. Yes, you are better. Yes.
Hello.
Yes, yes.
Yeah. So my question, see, every time the rhythm cannot go as we want, there will be a twist and test. So think as if it is a patient. You knew it. So I also know properly that you know it's cardioversion. But if you do
Yes.
not answer cardioversion, it is a kind of life-threatening condition. And if you do not answer cardioversion, no matter all the tips you answered, and if you do not answer this, you will be in trouble because they consider this as a blunder.
Mm-hmm. Yes, ma'am.
So don't have a tunnel vision, have a broad vision. Think it as a patient. If you are in OT, if a patient is hemodynamically unstable, definitely you have to speak. We will go to with 3C: crash cart,
Yes.
conscious sedation if the
Consent.
patient is GA, and consent.
Mm-hmm.
And then we will cardiovert the patient.
Yes, ma'am. Mm-hmm.
You have to be careful here because what I'm trying to say is if you answer like 70% of the article, whatever you mentioned, you pass. But if you do a blunder, you will be in trouble. So I don't want that. So you need to, like, you should have that capacity to jump from elective to emergency scenario. So you make yourself that sharp. Okay?
Yes, ma'am.
What
Mm-hmm.
is your exam,
Yes.
Dr. No?
Sorry, ma'am.
When is your exam?
Mine is on September.
So you have time. So I think you need more of Viva sessions to sharpen yourself, right? Yeah.
Yes, ma'am.
So this is the article from which the question was framed. So you answered the anatomy correctly. So this is called as the hepatic. How do you define portal hypertension? Gone are those days which information and definition you using. Now it is hepatic venous pressure gradient. That is the gold standard for assessing portal hypertension, and it has a prognostic value. They hello.
Yes, ma'am. Yes.
So they do a hepatic venous catheterization and they measure the gradient. The balloon is kept at the venous pressure and free hepatic venous pressure. So they measure that gradient. Normal up to 5 is okay. If it is more than 6, with the clinical manifestation like vessel bleeding and liver, it is generally more than 10. So you have to answer portal hypertension is defined as a gradient, the hepatic venous pressure gradient of more than 6 mm of Hg. And generally when the patient is in a decompensated phase, it is more than 10.
Okay. Yes, ma'am.
Okay? And then I asked you what are the features of alcoholic liver disease. So you can classify here what happened. I could pick up that you have read this thing, you have the knowledge, but you are not organized. So you're trying to organize in the process of answering. That is why you are haphazard. So here you can write signs of acute hepatitis like jaundice, tender hepatomegaly fever, signs of chronic liver disease, like pulmonary arrhythmia, diffuse contracture, spider nevi, bruising, carotid swelling, gynecomastia, hepatomegaly. Portal hypertension is always a triad of varicose, abdominal varices, splenomegaly, ascites. And finally, poor nutrition. If you want, you tell. If you don't, it's okay. So at least you should know. And a bit on what is alcoholic liver disease, what the type of hepatitis, what are the most common cause of hepatitis. So a few basic questions you need to know. Okay.
Yes. Yes.
Did I share the article or which article was being displayed? This only was displayed, no? Or the other one?
Yes. This one.
So
Alcohol and liver.
yeah. So next we move to the indication. So causes of portal hypertension, what you mentioned was right, pre-hepatic, hepatic, and post-hepatic. And they also might ask you what are the diuretics being given. If you say it is spironolactone, they will ask you the class, because diuretic is one of their most favorite. I think last time Dr. Dikshita covered. So diuretic is very close to them. So they will ask you what is spironolactone, what is the class of the drug, what is his side effect, what are the issues, is a low ceiling, high ceiling, where does it act? They can ask, take you to diuretics from here. Okay.
Okay.
What are
Yes.
the indication? It has significant evidence for only two things, refractory ascites and varicose. The question that I put to you was, what is the indication of TIPS in this patient? So your answer should have been refractory ascites and varicose.
Yes, ma'am.
What are the contraindication? All the cardiac condition which you came up very lately. Rather than saying what is the normal contraindication to all the procedure, the same will be the contraindication. That is some answer which you talk to yourself, not to the examiner.
Mm-hmm.
To the examiner, you have to be kind of more professional. You don't tell this. This shows your weakness because you're trying to gain the time to answer. That's why you spoke some line like that. So be okay. So just count. Okay, heart failure, severe tricuspid regurgitation, severe pulmonary regurgitation when there is a multiple hepatic cyst, presence of sepsis and biliary obstruction. Then
Yes, ma'am.
I asked you about the preoperative. This was you're fine with it. Preoperative workup was fine. Only thing here, I would suggest platelet count you mentioned is 50 is fine, but INR is less than 1.5. You mentioned 1.7, I think.
Yes. Yes, ma'am.
Yeah.
Somewhere
So
I
if
read
it
it
is,
is
if there is,
1.7 for chronic liver disease. I don't
see,
remember.
Dr. Anu, point is,
Depending
why
upon
I would say
procedure.
1.5?
Yeah.
No, this is a
Okay.
BJ article. So for this exam, I know patient will have coagulopathy, so 1.7 is not actually wrong. It can be done. But since this is a EDAIC exam, they follow either BJ or ATOTW. So you have to, at least if you say the number, you have a backup of evidence from where you're talking.
Yes, ma'am.
So if the
Okay.
platelet is or FFP, you need to transfuse this preoperatively and get the numbers. And if it comes to varicose bleeding, the restrictive transfusion threshold of 7 gram per DL has to be given. So I was trying to take you through renal impairment investigation like urea because of the hepatorenal syndrome. Second is there will be hyponatremia as a hypervolemic hyponatremia. So, and third is albumin because they have to replace it with albumin. Okay.
Yes.
So I
Yes.
wanted you to talk on here, but you did anytime came up with the particular portion. Then presence and severity of hepatic encephalopathy should be assessed preoperatively. Coagulation screening and all was fine. I think you mentioned about echo. Echo is a must, TTE, because heart failure and tricuspid pulmonary regurgitation are a contraindication.
Yes, ma'am.
So you mentioned ECG with more of stress, but not echo. Echo is more important than ECG in this patient. Then I asked you about the GA and RA. So what are the points in GA? Definitely this is you want to secure the airway because this is a high risk of bleeding if their aspiration will happen. Second point, put it like this is a remote site anesthesia. So if there is a decrease in consciousness intraoperatively, it is very difficult to secure because of the limited space. Okay. Third thing is patient might have hepatic encephalopathy
Yes.
preoperatively, right? So if you give any sedation and all, that can compromise the condition even worse, like if it is an inadequate plane. Like the surgeon won't receive that much of cooperation if the patient is in hepatic encaph. So to provide a stable field for the surgeon as well, we need a general anesthesia. What are the side effects? Is definitely the effect of the multiple drugs we use. Okay, patient have delayed recovery. This is a daycare procedure, so obviously nobody would like to have a delayed recovery, right? So whenever you are given, because in this exam they are definitely they are asking the choice between GRA most of the time. So put your points in a it's like stepwise manner. Don't jump, and you don't try to repeat. Just talk 1, 2, 3.
Yes, ma'am.
Risk of aspiration, remote site anesthesia, better control of the surgical field. Then that's all. I didn't ask you. I asked you. Okay, this I didn't ask you. Might be asked about emergency tips. What are the indication of emergency tips? So higher side is the emergency. Post-operative, what are the problem? Hemodynamic is one issue. Okay. Then there can be, because of the intra huge bleeding, there can be hemolytic anemia. Okay. Hepatic encephalopathy is one of the important. So I was asking you what to be given, lactulose and rifaximin. One of the important is because that this happens because of the increased shunting. So you have to go for a shunt size, or you might have to occlude the tips. If needed, you can go for a transplant.
Okay.
So these are the few things. So post-procedural sepsis is also very one of the feared complication. So encephalopathy, your hepatic encephalopathy, sepsis, hemodynamic instability, and chronic is hemolytic anemia. Right?
Yes, ma'am.
Yeah. So any doubt from here?
Ma'am, you asked what is the MEL score for, the MEL score for tips or the Child-Pugh score for tips. What was it, ma'am? It will be A and B, isn't it?
MELD more than 15 is one of the indication for tips.
Okay.
So this is what exactly I asked is what is the indication of tips in this patient? So I wanted her to answer as refractory ascites and varicose bleed. Other thing is high MELD score.
Okay. Yes, ma'am. Okay.
So it is not written as one of the indication,
Hmm.
but it can be. You can answer it as one of the indication, extended indication.
Okay. Thank you, ma'am.
Right. Yeah. So no, you did good. Overall, you did good, but except for that blunder, I should say. Rest all was good. So I think if you and hepatic encaph you mentioned correctly. Still, I will show you. So we will discuss this article as well. There is something called as the West Haven criteria. Okay, so they have grade as 1, 2, 3, 4. If you can just remember the name of the criteria. And as you correctly mentioned, initially there will be short attention span. Second time, there will be inappropriate behavior and minimal disorientation of time, place. Third will be somnolence and confusion. And finally, in grade 4, it will be comatose. So there are two types of here, at least the same thing, but they have put it as liver flap or exteresis in grade 2. So this is the latest one, and for ATOTW, so I would say you follow this West Haven criteria.
Okay, ma'am.
Okay, so again we have so many things to cover. We will take a break of 5 minutes if that's okay with you. If you people want, I can continue, but I'm more worried for you because we have to discuss, I think, minimum 7 more scenarios. So if you want, we will take a break or we'll finish liver and take a break, whatever you say.
Continue. I feel,
Okay.
I mean, I don't know about others, but
Yeah, because liver, there are two topics, one acute liver, one chronic liver. So there are two topics left in liver. So if you all rest of you also are on the same page, we can actually continue. If you feel tired, then we'll take a 5 or 10 minutes break. Because your exam are nearing, even I don't want to wish to just waste your time. Yeah. All okay, or you want me to take a break? Quick.
Okay, ma'am. We can continue.
Fine. So who is coming up next? So I think Dr. Dhanya is left. Rest all have done one round. Dr. Dhanya, are you happy to take up now?
Yeah, ma'am, I'm in hospital. I'm on call. Before I got a call, that's why I left in between. If I get a call, I need to go. That's the problem.
Okay, if you get a call, then Dr. Aditya will take over because he has volunteer. Fine?
Okay.
Yeah. So you have a 62-year-old male with a history of liver disease. Complaints of repeated hemoptysis is posted for a lap hernia surgery. Okay. The patient is a diagnosed case of liver disease. So can you tell me what are the spectrum of liver disease?
Spectrum like acute,
Very good.
then acute on chronic.
Okay.
Then from acute, there is acute liver injury and failure.
So how do you define acute liver disease, liver failure?
Liver failure, there will be coagulopathy and encephalopathy. If there is only coagulopathy but no encephalopathy, then it is injury.
Very good.
And acute and chronic is a patient who is already having a chronic pre-existing liver disease, which acute worsening, current sudden decline in LFT, liver function.
How do you further classify your acute liver failure?
Acute can be classified into hyperacute, acute, and subacute. Hyperacute is worsening within 7 days. From jaundice to encephalopathy. So then next is 7 days to 28 days, and subacute is 20 days to 3 months. 3 months.
Okay. Fine. So can you tell me what are the extrahepatic manifestation of liver disease?
Extrahepatic, okay. Patient will have from like in the lungs, patient might have based for initially hydrothorax, pleural effusion, then hepatopulmonary syndrome or portopulmonary hypertension. And in the cardiac patient, they will have like a hyperdynamic circulation, which can lead to right heart failure, left heart failure, TR, tricuspid regurgitation. Then they might even present with effusions, pericardial effusion. Then in GIT, renal, there is hypoperfusion leading to renal injury, or there could be hepatorenal syndrome. In CNS, there might be hyperammonemia leading to hepatic encephalopathy. They can even present with intracranial hemorrhage. Then GI, delayed gastric emptying.
What is
So, what, ma'am?
and cirrhotic cardiomyopathy.
Um,
Okay, fine. Go ahead.
not,
Go ahead.
yeah. I am not getting it. Then patient will have coagulopathy because of the reduced production of coagulation factors. Thrombocytopenia will be there. High fibrinogen levels might be low. There is a pro-thrombotic state as well as a hypocoagulable state.
Tell me what are the pro-coagulation factors that is increased and what are the hyper anticoagulant factors that is increased?
So anticoagulant like protein C, protein S is reduced, and factor 8 von Willebrand factors are increased.
What about plasminogen?
Tissue plasminogen. TPA, I'm not sure.
Okay, what about the anticoagulation factors?
Like fibrinogen level and all might be reduced, ma'am.
Okay. Okay, fine.
Platelets might be reduced. Platelet function might be reduced.
Can you define me what is pulmonary hypertension and what is hepatopulmonary hypertension?
Portopulmonary hepatopulmonary syndrome is the arteriovenous, that is because of the vasodilatation. The alveolar arterial gradient is elevated. And other one is because of the portal hypertension. Correct, ma'am?
Any definition you know?
Yeah, portal. Arteriovenous gradient is more than 10
Yeah.
in hepatopulmonary syndrome. There is dyspnea, there is desaturation, PaO2 will be low with a large gradient, alveolar arterial gradient. Other one, there will be portal hypertension, that is like portal hepatovenous portal gradient of more than 6.
Okay. So how do you risk stratify this patient preoperatively? Like the patient has cirrhosis and is posted for a elective surgery, like a hernia repair. So how do you risk stratify the patient preoperatively?
Ma'am, child score or MEL score?
I think I'm asking you, how do you say, like this is the cirrhosis, if child focus is more than child focus is C, then you will cancel, or what is the recommendation? Like how do you decide preoperatively whether you can take up the case?
Okay. If it is a child pug A or B, then A you can proceed without proceed with caution, and like MEL score of 10 to 15, or child pug B, and you have to maybe optimize the patient. But if it's more than MEL score is more than 15 or child pug C, then better to defer the procedure or opt for a different. 1 minute, ma'am. Can I take the call?
Yes,
It's
sure.
okay. I think it's okay if they call again.
Yeah. Anything with the MEL?
MEL score of more than 15, it's not good to proceed. You have to look for alternative plan. 10 to 15 optimize prior to procedure, and less than 10 you can proceed with caution.
So any other thing also you wish to take up? Like one is the severity of liver disease. What are the other things?
Then depending on the procedure, whether it's a high risk procedure for bleeding, intraoperative bleeding risk. But this is hernia, ma?
Hernia.
Hernia surgeries, it's not considered a major bleeding risk. procedures, I think.
Mhm.
Mm.
Okay, what
Then
are the
if there is any compensate, like patient is having the severity, like if it's a decompensated acute failure.
Mhm. So hernia repair, what do you put the hernia repair as? A low?
Oh, ma'am, 1 second.
Yeah, pick up.
Hello. Hello, ma'am.
Yeah.
Yeah.
Do you want to go or you're here?
Yeah, it's okay. It's okay.
Fine. So, how do you rate hernias? High risk or?
No, it is, ma'am, inguinal hernia, ma'am. I did. Yeah. This procedure.
So, apart from CTP, childhood scoring, are you aware of any other scoring system for
Yeah,
end-stage liver?
there is newer models like vocal pen model, which has which gives other, like not just creatinine or INR and bilirubin, but the patient factors are also taken into consideration. Surgical factors are also in.
Very good.
So vocal pen model, and there is one Mayo Clinic.
Very good. Very good. Okay. Fine. So, how do you do the pre-operative optimization, and what are the investigation you'd like to do?
So investigation, ma'am, normal CBC, liver function, renal function, electrolytes, coagulation, PTA, PTT, INR, and fibrinogen levels.
Target
Then,
fibrinogen.
ma'am, it should be more than 1.5.
Okay, if suppose the fibrinogen level is less than suppose 0.8, so
Okay.
what do you wish to give? Which blood product?
Ma'am, if fibrinogen is less, we can give either thrombin complex concentrate or thrombin complex concentrate.
Fibrinogen
Cryo we can give them.
or FFP?
No, cryo is preferred because of lower volume and higher concentration of fibrinogen.
And what about platelet? What is the target platelet?
Target platelet, I think more than 50,000 platelet should be normal for procedure. Unless
So,
regional procedures are.
1.9.
What, ma'am?
If INR is 1.9, so what you will give?
We need to correct that. We can here actually FFP. Initially we used to give FFP, but now I think IN we need cryo.
So why FFP is not preferred?
FFP doesn't correct it below 1.7, and it gives a larger volume, so more complications with FFP and more chance of infection also with FFPs.
Okay. So what is the point of care which can you can use to
Take
decide?
Rotama.
What are the intraoperative concerns?
So intraoperative patient will have this is for hernia surgery laparoscopy, ma'am.
Yeah, put it as laparoscopy.
Okay, like because of the laparoscopy also there will be more of hemodynamic changes, so we will require an invasive monitoring. Patient might have a difficult cannulation, so initially only maybe we might need a central venous catheter. Make sure, otherwise we have 2 wide bore cannulas available. Then if coagulation abnormalities have a bleeding risk is more, we should be able to at least arrange blood prior to procedure. They might have received multiple transfusions prior, so they might have antibodies, so might require time for arrangement also. And they are so blood arrangement should be done prior to procedure, and then avoid all causes of
Can you
increased blood loss.
you put a transesophageal Doppler because we need to have the cardiac output.
Ma'am, that is not recommended because of the more chance of variceal varices might be there, and it might cause rupture.
What are the goals of anesthesia in this case?
So avoid like all cases, ma'am, like avoid hypoxia, hypotension, avoid hypotension, maintain temperature, and hemodynamics, maintain hemodynamic stability, and blood sugars also you need to. Then ventilation might be also be difficult because of if patient has ascites, higher peak pressures might be needed, and yeah, ma'am.
Drug of choice for anesthesia?
For induction, ma'am?
Entire induction, then following.
Okay.
Following.
So
What are the drugs?
So for induction, I would prefer propofol in titrated doses, and like for muscle relaxant, initial dose, because I would want for a rapid sequence, I'll go with rocuronium. But for maintenance, and make sure that Sogamadex is available if in case. And for maintenance, I would prefer atracurium or cisatracurium because it doesn't, the metabolism is not affected by liver disease. And Tiva is also, Tiva I would go ahead with because propofol and Remi.
TCI?
TCI.
And what about inhalational?
Inhalational, ma'am, sevoflurane is okay. We avoid halothane, but halothane we don't use it now. So sevo or desflurane should be okay. Ma'am?
Why you wish to avoid halothane?
Halothane hepatitis is one thing. Then, yeah, higher, I think around 20% metabolized in the liver halothane. Compared to sevoflurane and desflurane is 0.2% and 0.02% metabolism in the liver.
What is the hepatic arterial buffer system?
I know that too. I am not getting.
So what is your how do you maintain the post-op analgesia?
Post-op analgesia, ma'am. I will try to avoid like longer acting agents like opioids. Block can be given like tap, subcostal tap. No, this is hernia. No? Like the tap block can be given, or inguinal hernia block.
Tanya, let's divide your answer as pharmacological. So you tell me what are the pharmacological drugs which can be given and the one which should not be given or can be best avoided.
So for pain, we can paracetamol in reduced doses or can be given still. NSAIDs are avoided because of the bleeding risk is higher. Then opioids is best avoided because of patients having hepatic.
Opioids or any specific can still give?
Ma'am, shorter acting agents, and fentanyl is fine, but post-op analgesia, it won't be. Ma'am, I can't hear you.
I'm asking about post-op analgesia. So if you give fentanyl, it is short acting, no?
Yes, ma'am. That
Oh, it's any better options?
opioids, morphine, but still you need to monitor for these are all having sedative effects.
So it is just a sedative effect you are worried for morphine or something else?
Morphine 6-glucuron, it's metabolized in the liver, so
Oh.
the metabolite can accumulate, and that also prolonged action, delayed recovery.
What about the interventional options?
Ma'am, tap block can be given, or ilioinguinal block can be given, or even erector spinal plan. I'm not sure about erector spinae, but yeah, tap block can be given. Ma'am.
What about epidural?
Epidural can be cited, ma'am, if depending on the coagulopathy. If it's within normal limits for insertion, then it can be done.
So post-operatively, the patient has altered sensorium, and what can be the reasons?
They can go into decompensated state. So hepatic encephalopathy can worsen. That is one reason. Then sepsis infection can occur. What else? Patient can develop peritonitis because any infection, ma'am, intra-abdominal
Can it be
infection.
hyponatremia?
Ma'am?
Can it be hyponatremia?
Yeah, hyponatremia. They are prone for hyponatremia. This because of increased ADH, ma'am.
Okay.
And
That is
ma'am?
That is one. What will happen if there is increased ADH?
Increased ADH because of the patient's hypotensive state, there will be increased ADH, so increased water reabsorption, so that will, and dilution hyponatremia.
Okay, what can be the other reason for hyponatremia apart from the one you mentioned? Fine. We'll stop you at then.
Yeah. Yes, ma'am. I don't know. I'm going from one place to another.
No, the good thing is at least I'm happy. Like at least for the class sake, you guys are studying the proper material. That is at least something. What you study
but
and
still not able to get everything in one place.
yeah, that's true. That's true. But anyways, not that bad, I would say. Rather, it's okay. At least few things you genuinely you didn't do good, but at least you are not blank. Because I have seen your previous Viva used to get like blank kind of thing. This time you are not blank. So I think your preparation on the right way. But yes, definitely you have to now even try to organize more so as to put the things in proper way.
Yeah. Yes.
Yeah. So I asked you the definition of liver disease, the spectrum, acute, chronic, and acute and chronic. Acute, correctly you mentioned. Jaundice, coagulopathy, I think you didn't put jaundice. You only mentioned about coagulopathy.
Yeah,
and
ma'am. Like in the, I think one article which I saw, even I had a doubt. They have not mentioned jaundice.
I've seen, but I think you should follow the BJ.
Okay.
Then O-grade classification has mentioned acute, and subacute, right? Then it comes to chronic liver failure, which you mentioned correctly, and acute and chronic. What are the extra manifestation? Hyperdynamic circulation with high cardiac output and low SVR. Relative hypovolemia. So I was asking you what is cirrhotic cardiomyopathy. So it is a combination of breathing diastolic dysfunction with prolonged QT, and there is a blunted response to stress. Okay.
Okay.
Then comes to what is hepatopulmonary syndrome, what is a portopulmonary syndrome. This is a Which screen you are able to see now? Yeah. So when you ask about portopulmonary hypertension, it is characterized by mean pulmonary artery pressure of greater than 25 mm of Hg and a pulmonary vascular resistance of more than 240 dynes per second centimeter at rest. Okay. So this definition are constant. You have to remember the numbers. Right? And what is hepatopulmonary syndrome? Hepatopulmonary syndrome is hypoxemia PaO2 of less than 60 who have no evidence of cardiac disease. And that, as you have correctly mentioned, they have a significant intrapulmonary vasodilation with delayed shunting. So there will be a wide AA gradient and platepnia.
Platepnia, I forgot. Yeah.
Most important. Yeah. So this is what I wish to say. You have to remember the two definition because they involve certain number as well. So here they have just written the dyspnea or hypoxemia in the setting of liver failure caused by intrapulmonary AV shunting. So that the other one I showed you.
And the other one I wrong. I said wrong. No, I was telling about hepatic portal hypertension values. No.
Yes, you're telling the reverse also. And portopulmonary hypertension will have intrapulmonary vasoconstriction.
Yeah.
Then GIT, I think you mentioned correctly. Renal, hepatorenal syndrome will cover later. That's why I didn't force upon, but you also didn't mention it properly. CNS was fine. Endocrine also you didn't mention. There will be adrenal insufficiency and secondary hyperaldosteronism. That is the reason of hyponatremia, which I was asking you. When it comes to coagulation, you procoagulant factors you are very good at. You didn't mention properly on anticoagulant. So whatever factor is not there in the procoagulant and they will be in the anticoagulant, no? So 2, 5, 7, 9, 10, and 11. Vitamin K deficiency, increase in TPA. Okay, because here plasminogen is decreasing. So obviously here plasminogen is decreasing means increased TPA will happen. Okay. So you need to know this hemostatic control. Okay.
Yeah, good.
Fine. Then I asked you about the preoperative risk. You mentioned about childhood MELD. Also, you mentioned correctly. I wanted to ask you the components of MELD, but anyways, you only came up with your own, so I didn't have to ask you. Then there is something myoclinic and vocal pen model. So again, I would say detail is not that much needed, but whatever you mentioned briefly, like focal pain model takes many things into account, like the condition of exact condition of the patient, surgery, ASA grading. So this is more better for post-op mortality prediction in patient with cirrhosis. At least this much is needed. What you told was sufficient. And then I was asking you, how do you stratify? So ALF, ALI, if the patient, this is what I was looking forward, which you missed. So if the patient has ALF or ALI, you have to defer, cancel, or find alternate management. If the patient is TPA less than 10, then only you can consider proceeding with caution. It is CTB, B or MELD is between 10 to 15. You need to do with caution with post optimization, and C you have to cancel again defer. So ALF and CTB 3 you have to cancel it. Okay. Then risk of bleeding hernia, I do agree it's a low risk bleeding cases. Nothing much to say here. Then history examination, this part, yeah, this I was looking forward, which you didn't mention. So in history, what are the 5 things you need to ask is, what is the severity of liver disease? What if the patient has any extrahepatic manifestation of CLD? If the patient is decompensating ALF, because you have to cancel the case in those cases. Okay. And if there is autoimmune variant, if the patient is on steroids.
Okay.
Right. Pre-operatively, these are the few same thing. Whatever we spoke on the last case, same thing you have to repeat it here, except for CPET. You can do any liver case, anyways, you have to do a CPET to see for the for the reserve, and you need to do a hepatic venous pressure gradient also to look for the signs of portal hypertension. So here a hematological optimization is very important. So here you have to have because this patient will have coagulopathies. So you need to have FFP and cryo. As you correctly mentioned, FFP cannot correct below 1.7. It will increase unnecessarily the volume. It will not reduce the risk of bleeding, nor it will help you with increased thrombin generation. Okay, rather it can worsen the hypercoagulability. So they might ask you what are the advantage of cryo over FFP in this, in particularly in cirrhosis. So as you
I'm
three,
just
four,
taking the call.
yeah. So coming to ROTEM is very much important, and as she correctly mentioned, the fibrinogen should be, she told 1.5, it is 1, and if needed, go for cryo or over FFP, and platelet it is 50,000, right? Then intraoperative management, yeah. AKI, they will be at a high risk of AKI. So fluid management is very important. Go for an invasive cardiac output monitoring like PICO, LIDCO or flow track. No issue or no point of giving esophageal Doppler because the patient has a esophageal virus. It's a relative contraindication. So I was asking you, what is the optimal anesthetic management or the goals? So which she didn't mention it properly, to minimize the blood loss by avoiding the hypothermia, acidosis, and the hypocalcemia, which are the triad of death. So you should minimize the blood loss, and this is how you do it. If needed, you have to go for the vasopressor drug, and that too once the fluid status is maximized. In these cases, terlipressin may be added if SVR is low. Second is prophylactic antibiotic is important. Third is you should avoid hypoglycemia. Generally, this patient is, if is posted for hernia, you need not give GA itself. If there is no signs of coagulopathy or optimization has been done properly, you can go for a regional technique also like spinal. Okay. If you are going for a GA, then you have to ensure that none of the time the patient hepatic blood flow should be decreased. And what is hepatic arterial buffer is, if there is a decrease in the blood flow in the portal vein, hepatic artery can do something to maintain the flow, though its contribution is minimal. But if there is a decrease in the hepatic artery, portal vein cannot compensate. All our anesthetic drug mainly affect the hepatic artery. You have to have your regimen in which, like, halothane will affect the hepatic artery the most. So you should avoid halothane. One of the other reason apart from the two she mentioned. Second is, either if you are going for GA, then the advantage is that intraoperative hypoxia will be reduced. Okay, suppose the patient is going for a laparoscopy. So that time anyway GA you will give, and intraoperative hypoxemia because of the abdominal pressure, high abdominal pressure, there will be diaphragmatic splintering and further VQ mismatch will be high. Drugs have altered drug metabolism and the altered synthesis of plasma protein binding. So you need to have a drugs which are minimally affected. Pre-medication with the sedative should be avoided. If you are giving propofol with IV, though the you have to give in a graded manner, because the and also a reduced dose, though the volume of distribution is increased, but at the same time the effect on the cardiovascular system will be too high. So patient can go for a sudden decompensation. Among the muscle relaxant, Atrans, etc. are the best. Okay. Again, you have to ensure the patient doesn't have acidemia, because in the presence of acidemia, even this will get prolonged. The effect of Atras, etc. also is
Ma'am, anyway,
get
but
prolonged.
we will tell for rapid sequence only, no, ma'am?
Yes, you have to know. You can always say, I will check for the coagulation parameter. If the coagulation profile is normal, I can go for a neuraxial blockade.
Okay.
If the patient is in a decompensated failure, or the patient has with the child book A or B, but coagulopathy is there,
Hmm.
then you can always you have to go for a GA. Then you talk about all this. So give them an option. RF also an
Okay.
option. The best is TCI, also if needed, and halothane has to be best avoided. And remifentanil is for intraop analgesia is an excellent choice. Morphine should not be, generally better to be avoided because it reduces both the hepatic blood flow and high for morphine, right? So post-operatively, you can give oxycodone and tramadol. NSF should be avoided. You can go for a tab block or ESP, whatever you mentioned, but epidural also can be given if
Okay.
needed. I'm not saying this case is for her. Ileointestinal ileohypogastric. It suffices the work. If I say this case is a LSCS or some other case there where you need a good analgesia also, if a coagulation profile is good, you can go for a epidurals.
Okay.
And post-operative hyponatremia, I gave you a scenario. So obviously post-operative hyponatremia, that are the two causes. One you mentioned, or already you mentioned the point, the increase ADH. And other point is because of over diuresis also there can be hyponatremia.
Okay.
Okay. Fine. Any doubt over here?
Hmm. Ma'am, for just not everywhere pulmonary artery hypertension, no, ma'am. Here also wherever it is 25 only, no, ma'am.
Yes.
No change with because I had something doubt in clinical. They were saying in females it is might be higher. Nothing like that, no.
I didn't get you. Can you repeat once more what you
Like
asked?
25 above 25 pulmonary arterial we define it as pulmonary artery hypertension, no. No change with gender, female, male, any difference in the values.
I don't think there is a change with gender. If at all, it is not that significant.
Yeah.
Okay. So who is coming up for the next one? Yeah.
Yeah, I can.
Yeah. Dr. Aditya, I will put the question in the chat box. Just you read. In the meantime, I'll just get back in 1 minute.
Oh.
Yeah, I'm back. So can you tell me what are the indications for liver transplant?
There can be various indications for liver transplant, some of which are like the alcoholic liver disease, hepatitis B or C, liver cirrhosis. There can be paracetamol overdose, then acute viral hepatitis. Then
Which is
there can be
viral hepatitis. What is the most common viral hepatitis that follows the liver transplantation indication?
Hepatitis B.
Okay.
Then there can be acute liver failure in pregnancy. Then autoimmune hepatitis, primary biliary cirrhosis, and sclerosing cholangitis.
Very good. So what is the difference between MELD and MELD sodium? Means what is the added advantage
MELD,
of MELD over MELD?
MELD is a MELD consists of serum bilirubin, INR, and creatinine. And MELD sodium along with it
Am I audible?
also sodium. Yeah. So it is a better
Hello?
prognostication tool. Yeah, hello.
Why? Why MELD sodium is better? Why MELD sodium is better?
I don't
Can
know.
you repeat? Actually, I think you answered it correctly. I didn't listen it. Can you please repeat because of some network issues was there?
It is a better prognostication tool for patient waiting for liver transplant, MELD sodium, because it also takes into account sodium, which is electrolyte necessary for neurological as well as hemodynamic stability during the surgery.
What are the other points? What is the component? What are the points in MELD that they take into account?
Serum bilirubin, INR, and creatinine.
Okay, fine. So can you tell me what are the preoperative consideration for this case?
Preoperative consideration is a complex procedure. Liver transplant is a complex procedure and high risk procedure. So proper anesthetic assessment is essential. And most of the persons are generally of elderly age group with many comorbidities. So we'll have to have a proper assessment of these patients, including any cardiovascular assessment like any history of IHD, ischemic heart disease, or any like CPET we can use, any history of cardiomyopathy and alcohol related liver diseases. There may be cardiomyopathy. We can also use transthoracic echocardiography to see for any LV dysfunction, ejection fraction, or there can be any medical therapy for heart failure in these persons. Then there can be pulmonary diseases which may further complicate the situation. And this could be hepatopulmonary syndrome, portopulmonary hypertension may be there. Hepatopulmonary syndrome may lead to vacuum mismatch and hypoxia. Portopulmonary hypertension, when the pulmonary artery pressure is greater than 50 mg, is classified as severe and can lead to worse outcome. We can also assess these with the help of the transthoracic echocardiography, and also for the volume status. Hello.
Yeah, continue.
And also we will see through the transthoracic echocardiography volume status of the patient, because these patients are more prone to volume overload.
My question is, what is the preoperative considerations or evaluation which you will look? So I'm not asking intraoperative. So preoperatively, you mentioned about portopulmonary hypertension. So can you tell me how do you evaluate the suitability of orthotopic liver transplant based on portopulmonary hypertension?
It is classified as severe with portopulmonary artery pressure greater than 50 mmHg. And most of the patients are moderate to severe portopulmonary hypertension, that is between pulmonary artery pressure 35 to 50 millimeters of mercury. And severe portopulmonary hypertension in the pre-existing cases is associated with higher mortality during the
If the
intraoperatively and
portopulmonary,
postoperatively.
if the portopulmonary pressure, if the mean pulmonary arterial pressure is more than 50, will you like to go with the orthotopic liver transplant or not?
It is actually controversial. In most of the cases, they have reported a higher mortality, but in some cases they have also reported a better outcome. So I will avoid
And suppose
greater
it
than
is
50 ml.
30 to 35 to 50, then whether you will go ahead or you need to know any other value as well before you take up the call whether to cancel or not to cancel.
We will look for LV dysfunction and RV pressures on echo.
Okay. So can you tell me what are the components of hepatorenal syndrome?
Hepatorenal syndrome is classified as type 1 and type 2. Type 1 hepatorenal syndrome is associated with higher mortality, and that is around
My
50%
question is,
or more.
first you tell me what are the clinical components of hepatorenal syndrome?
In hepatorenal syndrome, there will be renal worsening, or there will be rapid deterioration in renal function with a background of chronic liver disease. And in type 2 hepatorenal syndrome, there will be resistant ascites, resistant to diuretics.
Any other points?
Type 1 has higher mortality. And for type 2, we mainly use diuretics and mannitol.
Before going to types, I would say, can you tell me, if the patient is hypovolemic, but the patient has creatinine more than 1.5, will you call it a hepatorenal syndrome?
No.
So what are the prerequisites of
Because
hepatorenal syndrome?
patient should be, proper hydration should be there, and there should be a history of chronic liver disease. And metabolic abnormalities should be corrected. After that only we can call it a hepatorenal syndrome.
What are the screening investigation you would like to do in this case?
Basically, we will have to, in case of liver transplant or hepatorenal syndrome.
Liver transplant.
In liver transplant, I will like to see the liver function test, then any coagulation profile, then encephalopathy grading, if any, and also ultrasonography of the abdomen and CT scan of the abdomen. And blood investigations like hemoglobin, that may be decreased because liver produces most of the clotting factors also, and also helps in iron storage and all the metabolism factors, and urea, blood, urea, creatinine, electrolytes.
Would you like to
Hello?
go for echocardiography?
Yes, echocardiography we will do.
What do you wish to do? Echocardiography or something else?
We will proceed with in post-operative, intraoperatively, or what, preoperatively?
Preoperatively, would you like to go for echocardiography as well?
Yes, transthoracic echocardiography.
Yeah. So
And
you
we
want
will look for
echocardiography or a dynamic echocardiography?
a dynamic echocardiography will be more useful because
Why?
it will be, better assessment of the cardiac reserve, cardiorespiratory reserve, because they become apparent at a stress. Any abnormalities become apparent at a stress, so it can be recognized
What else you wish to
previously at
do?
a better level.
What else you wish to do?
Est-
Would you go for a coronary angio as well?
If required, we can go for a coronary angiogram, but not necessary.
Okay. What are the intraoperative monitoring devices you wish to do? You wish to attach?
Intraoperative monitoring devices, we will go for ECG, then intraarterial BP monitoring,
Hmm.
SpO2, temperature monitoring. Then we will also insert the central venous line, urine output monitoring. We can use for cardiac output monitoring, transesophageal echocardiography.
Okay.
And
What are the stages of surgery and the anesthetic implication at each stage?
there are 3 stages of surgery.
Mhm.
There is dissection phase, and hepatic phase, and reperfusion phase. In the dissection phase, previous liver is mobilized.
Can you bit loud, Dr. Aditya? You are again going away from your phone.
Just a minute.
Yeah.
Now, can you hear me?
Yeah, you're better.
There are 3 stages: dissection phase, and hepatic phase, and reperfusion phase. In dissection phase, the old liver is mobilized for removal. This could also result in some bleeding or massive hemorrhage. And in the stage 2, there is an hepatic phase, which is there is clamping of the IVC and the portal vein, which reduces the venous return by about 50%. And or to reduce this, we can piggyback the IVC, or we can use a veno-veno bypass. But veno-veno bypass is associated with more problems, so it is usually avoided. In the reperfusion state, there is release of potassium and other vasoactive metabolites, which leads to hemodynamic stability. And we can also minimize this by giving judicious fluid administration and piggybacking the IVC.
Okay. Then?
Then about monitoring, I have said, and
No, apart, what
fluid
else you will
management.
take? About hemodynamic, what else you will take care?
We can also use some inotropes or vasopressor if required, and previously pulmonary artery catheter was traditionally used, but now transesophageal echocardiography is preferred. Also, in some cases, jugular venous oxygen saturation monitoring may be employed. There should be large bore IV access for fluid administration, rapid infusers for massive transfusions, and
This post-reperfusion syndrome?
the post-reperfusion syndrome may be associated with coagulopathy, including which has many causes like fibrinolysis, heparin effect, hypothermia, hypocalcemia, hemodilution. Also, the patient may become hypercoagulable at some time. And
What are the
also
risk
in
factors?
the yes,
How do you
and
minimize the
also
risk? How do you
hello,
minimize the risk of post-perfusion syndrome?
we can use thromboelastography to guide the therapy and antifibrinolytics like tranexamic acid and correct electrolyte imbalances like monitoring of potassium.
Which is more important than potassium? Any other electrolyte which you didn't mention also during the management intraoperatively, which is more important than potassium per se?
Mm, Potassium and sodium as you said before. Hello.
Yeah, I'm listening. More than important, more than not sodium, anything else? Okay, fine. So what are the post-operative concerns?
Post-operative concerns. My post-operative concerns will be early extubation and fast track the patient for mobilization. But for this,
What are
I
the
will
signs of
also
early
maintain.
what are the signs of graft function? Like what if the graft is working properly or not? How can you, what are the signs to that denotes the same?
There can be decrease in the blood flow to the if graft is not working properly, there will be
No,
increase
no, no.
in the
I'm
liver
asking
function test.
post-operatively, what are the things that we will look at to ensure that the graft is functioning well?
Okay, we will maintain the proper blood pressures, avoid hypotension, hypoxia,
No,
acidosis,
Dr. Aditya,
hypercardia.
Dr. Aditya, my question is,
Yeah.
how do you ensure the graft is functioning well? What are the clinical signs or investigation that will help you to see that the graft is functional? I'm not asking how do you prevent graft failure. I'm asking how do you ensure the graft is functioning well?
We will look for the any deterioration in liver function tests. Then also the signs of any ongoing or severe coagulopathy, any increasing infections like sepsis, decrease in urine output due to AKI.
Okay, what are the complications of liver transplant?
There can be bleeding and electrolyte disturbances. Then coagulopathy, metabolic acidosis, graft rejection, immunosuppression, sepsis.
Fine, we'll stop you here. You did.
I tried to answer, but some questions I could not.
Yeah. So compared to the first one, this was better. But few things, Dr. Aditya, what I can ask you is that Suppose I'm asking you a question, I think the interpretation of the question is a bit difficult. Means you are not interpreting the question properly. Like I asked you, what is the signs of a good functioning? Like if I say a free flap, I think you must be doing a free flap for sure for tumor surgery, head and neck surgery. They do a free flap, right?
Yeah.
Yeah. So how do you check for the function of the free flap? So what we do is we look for the perfusion, we look for the CRT kind of thing. They put a micro needling and see if it is, and the color, then what is the flow, then like they compare the color of the free flap to the normal skin. That is, these are the indicators. Similarly, for the liver, what will be the indicator? If the metabolism is improved, your temperature will improve. If glucose, you have been saying will take care of hypoglycemia. So obviously now if there is a liver has improved, means glucose level will either be normal or improved. Right. Then
Yes.
coagulation profile, which was bad, will improve now. So these are the signs to see bilirubin level will get down. When it comes to kidney, what we look for? Urine output has improved or not? What is the trend of creatinine now? So these are called the signs of improvement. And I think again and again you're trying to confuse, like you're telling me, how do I ensure? So 2-3 times has happened. I felt like what I am trying to ask and what you're answering are not it's a kind of mismatch. So I would just suggest you listen to the question properly. Huh? So what the examiner is trying to extract, it's a human tendency that we need what we know, we try to speak, but more importantly we need to give the information which the examiner is looking forward, right?
Right.
Yeah. So I had framed this question from two articles. One is from ATOTW, other is from the BJ. So what are the cause for the liver transplant? It's hepatitis C, which is more than B. You mentioned B more than C. Okay. Then melt sodium was fine. Then I was asking you what are the things you look for the preoperative consideration. So whatever Dr. Dhane had told, we same thing we have to go into each of the system. For the neurological, we have to look for the grade for the hepatic encephalopathy. For the hematological, you didn't mention. So the same question that the last question was asked, you have to look for the values and get the tag done. For the cardiac, you have to look out what is the heart rate, what is the, because it's a high cardiac output state. So you have to look for the signs of if there is a high cardiac output, low systemic vascular resistance is there. Okay. This question again, I was asking you, how do you evaluate the patient who is having a portal hypertension? So if you check for the mean pulmonary artery pressure, if it is less than 35 to 50 or more than 50. If it is more than 50, the candidate is not actually fit for an orthotopic liver transplant. If it is between 35 to 50, then you have to see for the peripheral vascular resistance. If it is more than 250 dynes per second per centimeter raised to the power of 5, then you have to cancel OLT. So this is very, very important. How do you take a decision whether to go for a suitability of orthotopic liver transplant using the mean pulmonary arterial pressure? Second comes your hepatopulmonary syndrome. That also you need to, the only definitive therapy for hepatopulmonary syndrome is liver transplant. However, because of the hepatopulmonary syndrome, it reduces the pulmonary reserve and it will increase the peri-op morbidity. That is why you need to go for a series of tests like CPET, okay, to look for the reserve, how much cardiac is protected. Third is vascular. So as you already mentioned, the portal hypertension will happen. So preoperatively, you have to optimize with the with the vasodilators, your uh, telepressin, your octiotride, whatever maximum better can be done. For the renal, as I already have discussed, it's usually hypovolemic hyponatremia and the two causes. But before you tag it's a hepatorenal syndrome, you have to exclude the other causes. Like the patient should have cirrhosis with ascites with a creatinine more than 1.5. But the other causes, pre-renal, renal, and post-renal should be excluded. Pre-renal means there should be absence of shock. Okay. And the patient should have been off of diuretics and volume expansion with albumin for at least 2 days. Then in the renal causes like any nephrotoxic drug or RPD should be excluded out. If you exclude the renal causes and then it is a cirrhosis with ascites, creat of more than 1.5, you can tag it as a hepatorenal syndrome. Okay. Here again, the definitive treatment of hepatorenal syndrome is a liver transplant. So next I asked you, then we come to the other article as well. Yeah. So in this I already mentioned cardiovascular. Yeah. So pulmonary hypertension, so here the patient might need phosphodiesterase inhibitor therapy. And when it comes to hepatopulmonary syndrome, why it happens? Because of the release of hepatic endothelin MON and consequent pulmonary endothelial NO production, right? So they will have orthodoxia, and the diagnosis of hepatopulmonary syndrome is confirmed with bubble echocardiography. Hematological, we have already discussed properly. So before in the pre-op evaluation, you have to have a multidisciplinary team. And what are the few investigation that you need to do is, apart from whatever list you mentioned, like blood tests, respiratory, cardiac evaluation, abdominal anatomy, others. So you need to have a echocardiography, and it should be preferably a dopamine stress echocardiography, because this will replicate the physiological changes seen during LT. Okay, so this I wanted you to come up with your own rather from my prompt. Second is CPT. So again, CPET is very important, as already mentioned, to look for the cardiac reserve, because respiratory is generally compromised. Coronary angiography is also very important, because if there is a CAD, then they have worst outcomes. So you may not go for invasive cardiac angio, but you can do a CT angio to look for the vessel's diameter. Okay. Then pulmonary circulation, I have already mentioned. You have to look for the signs of RV failure, pulmonary hypertension, portopulmonary tension, and all whatever I already mentioned. Then next comes what are the monitors you are going to use? So in the monitors, these are the all standard ASM monitors: central venous catheter, pulmonary arterial catheter, venous TE is important, warming device, then thromboelastography, rapid infuser, cell salvage, processed EEG. So you should remember the list completely. And then comes what are the phases and what happens in each of the phases. So as you mentioned, dissection phase, anhepatic and reperfusion phase. So what happens in dissection phases? This phase starts with the incision and ends with clamping of the hepatic vessels, the three: hepatic artery, portal vein, and the inferior vena cavas. So here, because they have huge ascites, the removal of the ascites will result in significant hypotension. So in this phase, we need to give a huge aggressive fluid resuscitation, which is cardiac output monitored. And volume expansion should be done with crystalloids and colloids. At the same time, you should ensure ringer lactate should be avoided, because it's a potassium containing fluid. It increases the lactate levels in your blood, which is not good in a liver disease. Okay. So here anesthetic focus is maintaining the hemodynamic stability, addressing coagulopathy, and because this are going as a preparation to the anhepatic phase. Okay. So you need to take all the care of three things: hemodynamic stability, coagulopathy, calcium, especially calcium, and electrolytes. Right.
Ma'am, this calcium hypocalcemia, why, because of the transfusions or anything else? Why does it occur?
Hypocalcemia will worsen the bleeding. That is why
Yeah,
you have to.
like why does it occur? I'm asking. Is it
No.
because of our transfusion only, or with the liver issues it happens?
The point here you have to remember here to avoid hypocalcemia, not
I
necessarily that.
know. No, that's not what I'm asking, ma'am. Now, why does, like, hyponatremia, we know the cause. Like, why does this hypocalcemia occur?
That is what
Is
I'm
it
saying.
because
Calcemia, first of all, blood transfusion, I agree, that is one of the point. But if it is a massive in liver disease, if they have recently transferred, hypocalcemia will be one feature, but it is not necessarily that every patient, like hyponatremia is a physiological issue.
Mm-hmm.
Sir, you should avoid hypocalcemia if
Yeah.
at all it is.
Okay. But not that in liver disease you might be seen.
No, no, no.
No.
Only
Okay.
if there is a blood transfusion, there will be hypocalcemia.
Okay. Okay.
So then coming your second step is, so here optimization for this clamping, your volume loading, administer your vasoactive agents and hypocalcemia if at all present, you need to correct it. Then second comes the anhepatic phase, where they remove the native liver and re-anastomosis of the transplant liver prior to vascular unclamping. So this phase is completely with the clamping and unclamping. So here the vessel is clamped. So you know, whatever, as you mentioned, the all the products, the anaerobic metabolism will happen. Here you have to minimize the blood flow, because if you give overflow, then the congestion of transplant liver will happen, which will be detrimental. So here you have to maintain the hemodynamics with vasopressor and avoid hypervolemia. Okay. And a prolonged time, like if because of the anapatic phase, the patient will definitely go for acidosis and hypocalcemia because of the lack of lactate and citrate metabolism here. At this phase, hypocalcemia does happen. So if there is hypocalcemia and acidosis, that will worsen your bleeding. Okay. Also, it will cause hyperkalemia. So here you need to correct calcium, you need to give insulin and dextrose, and you have to treat hyperkalemia as well. Then finally, reperfusion. So in the reperfusion phase, whatever vasodilator was made in the anhepatic phase, everything will run into the systemic circulation, and suddenly there will be a hemodynamic instability. And this will even happen more if there is a pulmonary hypertension or right ventricular failure. So a sustained 30% decrease in the MAP for more than 1 minute during the first 5 minutes after reperfusion is called as a post-reperfusion syndrome. Okay. And if the patient has a prolonged cold ischemia time, the chance of PRS will further increase. So you have to take care of hyperkalemia, and preemptively you have to administer calcium if there is a hypocalcemia of the second stage. Second is the sodium or THAM infusion to adjust the acidosis. And third is inotrope or vasopressor for the circulatory support. So this is one thing. Other thing they have given in a box if you don't want to understand, but I feel that is more good. So pre-anhepatic or the first stage, the section phase, you have to ensure the same thing has been written, but in points wise. So here hemodynamics, fluid management, this and coagulopathy are important. Second stage, here you cannot give much of fluids. You have to play more with the vasopressor. Again, you have to take a blood protective, like anticoagulation protective strategy, in which the blood loss is not major to be happened. So you have to correct coagulopathy and hypocalcemia, and you have to take care of the metabolic acidosis and hypokalemia. And finally, in the newer thing, there will be sudden hypotension because of the sudden rush of the anaerobic metabolites into your blood circulation. You should know how to manage it, especially the hyperkalemia and hypocalcemia. So these are the common complication that happens after a liver transplant. So this was the last question which I asked. Is that okay? Why everybody got so much silent? See, again, liver transplant, hepatic vein resection has been asked the maximum number of time, but I still remember Dr. Austin. He was a guy from, I think, Saudi. He told me he was back to back asked about this thing. He was completely asked about. This is a 3-part chapter. I broke into 3 parts. One, we spoke about the tips. Other, we spoke about a cirrhosis patient posted for elective surgery, and finally the transplant. So I think he was asked about transplant. The guy one before him was asked about the posted for elective surgery. So it's a huge topic. So I divided into 3. But if you see, there are only 3 or 4 articles which you have to read on liver, and don't follow any podcast any other book, because this is the update and you will not get so much of information from your books. And they are asking this small question: what is portopulmonary, what is when do you cancer OLT? So there is, for the liver, there is no meaning of referring to your podcast or anything. Maximum your basic question: blood supply, what are the factors affecting blood, liver, like many things I also didn't discuss in basic sciences. What is the blood supply and how do you, what is sometimes they had asked about to draw about a portal triad. What are the contents of the portal triad? What are the zones? So all very basic question that you follow your podcast. But for clinical part, 3-4 articles are the most important, which you should read and go. Right? Hepatic arterial buffer system. What is the auto-regulation of, how it is auto-regulated hepatic blood flow? Kidney and liver, I think they had asked a good on the blood flow part. So you get ready for the same. In clinical, whatever we have discussed.
Ma'am, what about acute liver failure? Is that important for the exam?
The paracetamol, because it is one of the most common toxicity in UK and one of the most common reason of liver transplant, they have focused on paracetamol. So I would not rate it as a very frequently asked question, but paracetamol toxicity has been asked. So you should know that what are the indication. We will come. We'll just in a quick glance we'll finish off that question.
Okay, ma'am.
Yeah. So who is coming up next? So Dr. Nupur, if you are okay, we can pick up you only because you have asked this question. Dr. Dhanya, you wish to answer? Any one of you come up because we have long, as I mentioned, it's a very long class. We have long. By
Okay,
now,
ma'am. Okay. I am in hospital, but like, yeah, I can.
sure. If you have anything in between, we will pick up someone else. No
Yeah.
issues. So, a 55-year-old female with no history of liver disease present with ICU with ALF secondary to paracetamol overdose. She was found unconscious at home with empty paracetamol blister packs nearby. On admission, she is confused and drowsy. GCS is 10 out of 15. Blood pressure of 100 upon 60 mm of Hg, heart rate of 115 beats per minute, saturation of 95% on 4-liter oxygen, pH of 7.28, lactate of 4.5 millimole per liter, bilirubin goes to 4.2 mg per dl, INR of 3.2, and albumin is 2.6. ALT, AST both are around 3000. Right? What are the differential diagnosis?
So, patient was found unconscious with a tablet of strip of paracetamol, and her patient is acidotic with high liver enzymes, high lactate. Most probably cause will be poisoning or toxicity, and DD any like intracranial subarachnoid hemorrhage, acute on chronic liver failure. What a patient. DD.
Okay, how do you define and classify ALF?
Acute liver failure is derangement of patient with having coagulopathy, jaundice, and encephalopathy. And the same like acute, hyperacute, and subacute, no?
Very good. So what are the common causes of ALF?
Acute liver failure could be due to any toxicity, and then or patient with any hemodynamic instability massive blood transfusion. Then infective causes, ma'am, like viral hepatitis E, hepatitis A. Then in sepsis, multi-organ failure. Then in pregnancy, what, ma'am? Pregnancy, preeclampsia, HELP syndrome. Then
How do you manage this case now?
what, ma'am?
How do you manage this case now?
Okay. So patient is unconscious, so I will go with ABC approach. Secure the airway initially. Connect the patient to ventilator, lung protective ventilation with around 6 to 8 ml per kg PCO, and maintain PCO2. Then circulation, get to whiteboard cannula. Patient was tachycardic, not hypertensive. Ma'am, hypertensive?
No.
Yeah. So get to whiteboard IV cannula. Fluid resuscitation is important. Crystalloids are recommended, and if patient goes into hypertension, then we can go for noradrenaline or terlipressin. Then if patient is having...
So what are the risk factors for acute kidney injury here?
In this patient, like toxins, risk factor. Here it is acute poisoning, toxotoxin.
Yeah. So can this patient land up in AKI as well?
Yeah. Oh, yeah. Okay. Like complications, yes. Okay. Patient can develop acute kidney injury also. That is mainly due to direct renal injury, direct tubular toxicity of the drug itself with paracetamol, or it could be due to our like patient going into hemodynamic instability, hypotension, and acute kidney injury. Then they might even develop like intracranial hypertension. What else? Pain.
Okay, fine. So what is the criteria for referral to higher center?
I forgot. I have read that, but like patient is still remaining acidotic after fluid resuscitation with the acidotic pH and hyperlactinemia, which is not responding to fluid therapy, or deranged coagulation, or any renal or liver derangements even after our initial resuscitation.
Okay, 4-star post-hospital admission, the patient through seizures and had bradycardia and hypertension. What is the reason?
Most common is intracranial hemorrhage, ma'am.
Hemorrhage. Okay.
They are prone for intracranial hemorrhage.
What are the risk factors? What are the risk factor for ICH, intracranial hemorrhage?
So, and that is in patients who are presenting with a hyperacute state, severe derangement, or if patient is having severe high ammonia levels in the blood, so that will lead to like cerebral edema, worsening of the cerebral edema, and patients who are going into like septic shock patients, And
Okay.
Mm.
Can you
Mm.
tell me what is the specific therapy for acute liver failure? Yeah, paracetamol induced.
paracetamol toxicity, we can give N-acetylcysteine.
What's the mechanism of action of NAC?
It is a precursor of glutathione. Glutathione is required for the metabolism of NAPK and N-acetyl para-benzoquinone. So that normally paracetamol only 10% is metabolized to NAPQ, but because of the toxicity, the amount will be higher, and that is leading to the toxicity, and glutathione will be used up. So N-acetylcysteine is a precursor of glutathione.
Okay. When would you consider this patient for liver transplant?
Liver transplantation, if patient, I'm not sure, but I think it is not advisable if there is a irreversible brain damage.
Okay,
But
Dr.
it
Dhanya,
is, yeah, yes, ma'am.
I'll stop you here. How you?
I had read it, but I can't
I could see
recollect.
that you have read, but now you are not able to pick up.
Mm.
Have you read this article?
I had read one. Yeah, I have read that.
First two questions was the repetition of the other one, which you already answered. I'll ask you here. What is the difference between ALF and ALI? If there is no hepatic encephalopathy, it is ALI. If there is hepatic encephalopathy, it is ALF. Okay. Then we discussed about the spectrum. This also we had already discussed. Then I asked you about the causes. These are the causes: drugs, toxins, viral causes, pregnancy, vascular, other.
The drugs I couldn't remember. Yeah,
Okay. Then what are the tests you need to do? It is more or less the same thing, whatever we had discussed. Nothing more here. Your referral to a special. These are the few things which you should pick up from this article, which, as Dr. Nupur was asking, how important is this? Maximum this type of question they will ask you is what we are talking. That's all. It get too much stress, but you should know what from which part, what all to information to pick up. So if the INR is more than 3, PT is more than 15 seconds, or increasing hepatic encephalopathy, when there is hyperlactinemia or hypotension despite fluid resuscitation, pH is less than 7.35 with AKI bilirubin of more than 300 micromole per liter and shrinking liver volume on imaging. Because this extreme are actually the condition for liver transplant. So that is why you should first refer. Then you mentioned you will go for ABCD. Here you have to talk more because here the patient will have higher grade of, they have a higher grade of hepatic encephalopathy, you have to go for a airway protection. Second problem is ICP. You have to have a brain protective ventilation strategy also, so that the IP should not increase, ICP. Okay. So tidal volume of 6 ml per kg with the PCO2 between 4.5 to 5.5 and appropriate concentration of PEEP. Then coming to circulation. Maintain a map of more than start substances should be avoided because of the risk of renal impairment. Adrenaline, noradrenaline is the drug of choice. Terlipressin you can give for splanchnic vasoconcentration. If there is a cardiac dysfunction or failure, ADR may be added. Okay. Sorry, I was just looking. Terlipressin is generally used in cirrhosis, but here you should not use. It will precipitate ALF. One year, I was thinking some point was there here. Yeah. So this is one extra point that in terlipressin you should not avoid in ALF because it will worsen the condition. Okay. Then comes renal. What are the factors for renal? As you mentioned, older age is one. Already paracetamol induced. hypovolemia, hypotension, SIRS, and infection. Okay. There are few indication for renal replacement therapy because of the renal support and few for non-renal support. Renal support is if AKI is there. Non-renal support is if there is ammonia, hyperammonemia, so you have to remove the toxic metabolites. Sodium imbalances or hyperthermia or metabolic control. Okay. Then comes CNS. What are the risk factor for ICH? It can be again hyperacute or acute, younger age, renal cardiac dysfunction, SIRS, and persistent ammonia level higher than 200. Okay. So patient was presenting with cerebral edema only. So you have to have a monitoring for cerebral edema like venous jugular oxygen, optic nerve sheath diameter, NIRS, MRI. Okay. Then whatever we study for neuroprotective like head up position, maintaining normocalcapnia and normoglycemia. Okay. Neck should not be flexed. You should maintain a sodium constant between 145 to 50.
Okay.
Everything PCO2, you should not try to even make it, if needed, too much of ICP is raised, then will reduce or maintain a normocapnia and temperature between 35 to 36. Right. Coagulation can be a deranged coagulation. It will be as per the need, you go ahead. If you need a coagulation factors, like you can go ahead. Right. Finally, N-acetylcysteine. That also you mentioned correctly. And here is the King's College Hospital, London criteria for transplant.
Forgot, yeah.
For a paracetamol, what all to be done? If it is not for a paracetamol, what all to be done? This question is something you just write it somewhere and keep it for last moment revision. Because I myself had read and taught this minimum 5 to 7 times. But even I'm not able to register because I'm not doing such cases regularly. So even I tend to forget. So if you note it down and keep it somewhere, there are few things before the exam which is a must. Like you have to revise, then only you can answer. This is one of the table. Or just take a screenshot, make a folder or a PPT and just keep on pasting it. So that before exam, these are the few things which you have to revise. Right?
Okay.
Any doubt here? Dr. Nupur, this is what is maximum needed, not more than this.
Yes, ma'am.
But I have asked paracetamol toxicity, I think once.
Which one?
Asked paracetamol toxicity. And one small life in fast lane, if you guys are studying, I'm not sure, have you? Few people read this life in the fast lane. At times I read even I like. So if you see overall, no, they will write small things. What happens in paracetamol? How do you define paracetamol toxicity? Initially, what will happen? Next, what will happen? Then if you come down and down and down, they have given the dosages of paracetamol, of NAC. Okay, this is the prognostication is using O'Grady criteria. So this is the signs of progress. I know it is very difficult to remember so much, but having a watch like just one glance and go is not that bad. Okay. Yeah. Fine. So now we have done with liver. Liver is almost fully done. We have covered all the things in liver. Now I don't think you have to read anything apart from this in liver. Right. So we will next move to GIT. So would you like again a 10 minutes break or you want me the continuation? Blood or GIT? Whatever comes first. You want a 10 minutes break?
Ma'am, I'm happy to continue if others are, and I can go next if.
Okay, fine. What about others?
It's okay.
Or you need a... I'm
Can
really
continue.
happy today. I'm really happy that you guys are not giving any break to me as well. Right. So, Dr.
I was like, I know, 5 minutes
Huh?
of if you like if you
Pardon?
want, ma'am.
No. I can teach up to any 5 more hours also. I have no issues. It's just for you because I've seen You guys get tired, then you don't register. So that is why I asked. I have no issues. Fine. Dr. Nupur, it will be
Yes,
extensive
ma'am.
question, but important question. So how are the RBC produced in our body?
RBC is produced from the hematopoietic. First is the hematopoietic stem cells. From the hematopoietic stem cells is the burst forming unit of the erythroid colony. Then it's a colony forming unit, erythroid progenitor. Then is the colony forming unit of the erythroid progenitor. Then comes the erythroblasts, and erythroblasts then they form the reticulocytes with the help of vitamin B12 and folic acid. And from the reticulocytes, eventually, once they lose their RNA, reticulocytes lose their erythroblasts lose their nucleus to form reticulocytes, and the reticulocytes lose their RNA to finally form the RBC.
So what happens to the breakdown products of RBC?
RBC gets hemolyzed. They get hemolyzed in the liver. Bilirubin and biliverdin. Heme gets metabolized into bilirubin and biliverdin finally.
Okay. Then what happens to the biliverdin?
The bilirubin gets metabolized finally in the liver, and the biliverdin. I'm trying to recall now. It's long since I read.
And what about what about hemoglobin? Can you tell me what is hemoglobin?
So hemoglobin is made up of heme plus globin. So heme is there are 4 globin chains, 2 alpha and 2 beta, and heme is attached to each of the globin chain. And heme is synthesized from the protoporphyrin from glycine and succinyl CoA. And then heme attaches to it and to the
And how
protoporphyrin.
many molecules? How many molecules of oxygen attached to the hemoglobin?
4 molecules. Four molecules can attach.
Called property called as
Cooperativity.
what do you mean by the cooperativity or cooperative binding?
It's cooperative binding. So basically, hemoglobin is in 2 states. One is the tense state and one is the relaxed state. So in the tense state, the heme molecules are all apart, and it's the deoxygenated form where oxygen is not there. So at that time, a lot of resistance is required for the first oxygen molecule to bind to the heme molecule. But as the oxygen molecules keep on binding, it comes into the relaxed state. The heme molecules start getting closer, and the binding of hemoglobin to oxygen increases, and it goes into the relaxed form or the oxygenated form. This is known as the cooperative binding.
Okay. And what happens to hemoglobin in thalassemia?
In thalassemia is a hemoglobinopathy, so there is abnormal alpha and beta globin chains are produced. So depending on which chain is deficient, it is alpha thalassemia or it is beta thalassemia, and then depending upon the whether one of the chains is affected or both the chains, it can be a trait or it can be a proper thalassemia disease.
And what happens in sickle cell anemia?
So sickle cell anemia is a point mutation, just single gene mutation in the beta globin chain of chromosome 11. The 6th amino acid is replaced to valine from instead of glutamine. So there is abnormal shape of the RBC, which is called as sickle. So again, it can be either it can be a trait or it can be a dominant disease. It can be HBAS, which is the trait. So one is the HBA and the other is HBS, and the other is HBSS, which is the proper dominant disease. So in case of the trait disease, there will be less concentration of sickling, but there will be a sickling formation under stress conditions like hypothermia, hypotension, acidosis, hypercarbia, or certain conditions like infection. And in dominant disease, there will be more concentration of sickling. And these sicklings will then block the blood vessels and will lead to crisis situation, or it can lead to.
Huffner's constant.
Sorry, ma'am.
What is Huffner's constant?
Huffner's constant is the amount of oxygen which is carried by hemoglobin, and it is which is carried by 1 gram of hemoglobin. Yes, amount of oxygen which is carried by 1 gram of hemoglobin.
What is the number?
1.34 ml per gram.
Okay, what is total oxygen carrying capacity?
So total oxygen carrying capacity is 1.34 into hemoglobin into SaO2, which is the amount which is carried by hemoglobin plus the amount which is dissolved in the blood, which is 0.023 into PaO2, which is determined by the Henry's law.
Okay, what is anemia? How do you classify and approach to a case of anemia?
Anemia is defined as reduced hemoglobin concentration with respect to gender, altitude, and the pregnancy status of the body. So it is defined as hemoglobin less than, in males, hemoglobin less than 130 grams per DL, in females, hemoglobin less than 120 grams per DL, in non-pregnant women, and pregnant women, hemoglobin less than 110 grams per DL. And classification of anemia can be one due to anemia can be classified into 3 types. One, there is reduced production of RBC. Other is increased, whatever is getting produced, it's getting hemolyzed. And the third one is it is getting produced normally, but there is loss due to bleeding or due to other causes.
So can you give me a few examples of increased breakdown?
So increased breakdown can be intravascular and extravascular. So intravascular hemolysis can be if there is, like in sickle cell anemia, if there is any genetic abnormality of hemoglobin, then there is an inherited abnormality of RBC like hereditary spherocytosis. Then in RBC enzyme deficiencies like G6PD deficiency, there will be more methemoglobin formation, and that will be an extravascular destruction in spleen. Then transfusion reactions, then there can be autoimmune hemolytic anemia. And intravascular damage can also occur in some mechanical conditions like CP bypass.
Okay, so can you tell me what are the various blood conservative techniques?
Blood conservation techniques can be divided into preoperative and intraoperative, and it can also be divided into preoperative, intraoperative, and postoperative, and it can also be divided into anesthetic techniques and surgical techniques. So, preoperative techniques would be identification of anemia and correction of anemia. Most common cause of anemia is iron deficiency anemia. So, correction of iron deficiency anemia with oral or IV supplementation of tablets. Then, if there is any cause of any bleeding which is leading to anemia, identification of the cause and control of the cause. Then if the patient is on any antiplatelet or anticoagulant medications, then there are a group of patients like the Jehovah's Witness, identification of those patients and proper consenting of those patients. Then intraoperative techniques can be anesthetic techniques and surgical techniques. Anesthetic techniques can be hypotensive anesthesia, administration of tranexamic acid, then maintenance of proper temperature, pH, acid-base balance. then using point of care techniques, and surgical techniques can be use of minimally invasive surgeries like laparoscopic surgeries, use of cell salvage, then to use of tourniquets and topical hemostatic agents.
What are the relative contraindication to cell salvage?
Relative contraindications to cell salvages are cancer surgeries. They say that there is migration of the cancer cells on the body, and also sepsis, where they say that infection can lead to disseminated infection in the body.
So can you do to a sickle cell anemia patient?
Sickle cell anemia is also a relative contraindication, but there are few case studies where they have used cell salvage, and it can be used safely considering the risk-benefit ratio.
Cytoma?
Sorry, ma'am.
Pheochromocytoma?
It
What about
can be
pheochromocytoma?
used. It has been used in pheochromocytoma as well in most major abdominal surgeries.
Okay. So, any role of fibrinolytic?
Ma'am, just for blood yes, ma'am, I mentioned tranexamic acid
Yeah.
fibrinolytics.
Can you tell me the trial which is very famous with tranexamic acid?
Crash trial.
Which crash? There is crash 1, 2, 3. Which crash was about tranexamic acid?
It was crash 2, I think. I may be wrong. I think it was crash 2, which was for the tranexamic acid.
Okay, fine. So you have a 72-year-old male who is scheduled for a elective laparoscopic cholecystectomy due to symptomatic gallbladder, that's gallstones. He has a history of AF, hypertension, and DVT. He is on apixaban 5 mg.
Ma'am, sorry, AF hypertension and
Wait, I will paste it up so that
yes,
I will
ma'am.
see it up. So you have a 72-year-old male who is scheduled for an elective laparoscopic cholecystectomy due to symptomatic gallstones. He has a history of AF, hypertension, and previous DVT. He is on apixaban 5 mg PD, amlodipine 5 mg OD, atorvastatin 20 mg OD.
Yes, ma'am.
Yeah. So can you classify the anticoagulants?
Yes. So anticoagulants can be classified into the indirect NA inhibitors, which is unfractionated heparin, low molecular weight heparin, and fondaparinux. Then there are heparinoids, which is used in HIT, like danapuride. Then there are direct thrombin inhibitors like dabigatran, bivalirudin, argatroban, and direct NA inhibitors, which is rivaroxaban, apixaban, and edoxaban.
What are NOACs?
Sorry.
What are NOACs?
NOACs are novel oral anticoagulant drugs, which is commonly used now, which includes dabigatran, rivaroxaban, apixaban, and edoxaban.
Okay. So what are the pre-operative concern, key perioperative concern in this patient?
So the key perioperative concern in this patient is a known case of atrial fibrillation, but he's got a previous history of DVT, and he's on the therapeutic dose of apixaban, which is 5 milligram BD. So the choice between stopping his apixaban, which will lead to bleeding during the surgery, and continuation of apixaban, which will lead to bleeding during the surgery, and the decision to stop it, which will increase the prothrombotic risk of the bleeding. That there has to be balance. So apixaban, for anticoagulants, it is divided into bleeding risk of the surgery, like minor risk, low risk, high risk, or very high risk. And then it depends upon the
weigh between the risk of thromboembolism and risk of bleeding? Like, what are the criteria, or are you aware of any scoring system?
There is a Has-Blood score. There is a score which is known as Has-Blood score, which is used to decide the risk between bleeding and thrombosis. And according to the scoring, I cannot recall the exact number of the score. I just know that there is a Has-Blood score which is used to decide.
Thromboembolism?
Sorry?
What about how do you how do you stratify the risk for thrombosis? Suppose for this patient.
Mm. For AF patients, they start anticoagulants on the basis of the CHAD.
Can you tell me what are the components of CHAD's VASC score?
CHAD score is congestive heart failure. Okay. I do not remember the whole thing actually. CHAD is 2 VASC score, so it's congestive heart failure. H is for hypertension. Then is age, diabetes, then stroke, vascular disease like peripheral vascular disease. Yes, and that's the
So
CHAD.
in this case, what do you say? The risk of thrombosis is high, or risk of, how do you say this is a high thrombotic risk or a low thrombotic risk, high bleeding risk or low bleeding risk surgery?
So he's going to have a lap cholecystectomy. So it's an abdominal surgery. So it's a high bleeding risk surgery.
And thrombosis?
Thrombosis is decided on the basis of the CHAD-H2 score. So if the score is 0, it is low risk. If the score is 1, it is moderate risk. And if the score is more than 2, that is very high risk.
No, dear, what my question is, if I say the patient has, this patient, I gave you the scenario is in posted. Now you have to take the decision if it is a high risk or a moderate risk or a low risk, high bleeding, moderate bleeding, and low bleeding. So you mentioned to you it is a high bleeding. So it is according to it a moderate risk or high. And what is the implication of asking this question? Why I am asking to know whether there is a high thrombotic risk or not.
Yes, ma'am. High thrombotic risk, then when to stop the anticoagulant before the surgery.
So when you will stop for this patient?
So it is a high bleeding risk. So we'll have to stop at least 3 days before the surgery.
So how do you decide? Like for every patient, it is 3 days or something is there with a fixed
So
availability?
it is decided upon the risk of bleeding. So if it is of minor risk and low bleeding risk. So if it is minor risk, it can be like stopped for 18 to 24 hours. For low bleeding risk, it is 24 hours, but if it depends upon the creatinine also, creatinine clearance. If it is deranged, then 36 hours. But if it is a high bleeding risk surgery, then it is 3 days.
So what about bridging therapy? Do you consider bridging therapy in all the patients?
Bridging therapy, yes, bridging therapy is decided according to the risk of thrombosis.
So now you have the risk of thrombosis in this patient. So then we can decide the risk of if we will go for a bridging or not.
Yes, ma'am. The Has-Blood score is used for deciding the. So the
So
score,
how
it is.
start the
Sorry.
anticoagulant post-operatively?
Sorry.
How you will start the anticoagulation post-operatively?
So anticoagulants are mostly restarted after proper once initially it is the low molecular weight heparin is started once the proper hemostasis is achieved, and if the surgeons are happy, ideally it is started 12 to 24 hours later, and then once they are happy, it is converted back to the oral agents.
Fine. So, suppose this patient is on warfarin.
Mm-hmm.
How do you reverse the effect of warfarin?
So warfarin is usually reversed with, if it's emergency surgery, it is reversed with vitamin K and prothrombin complex concentrate.
So, what is the onset time of vitamin K for its action? And you mentioned it's a emergency surgery.
Quick onset, but I don't remember the exact time. It's quick onset, that's why it is used.
Anything which acts faster than this?
We can get the direct products like PCC for warfarin, ma'am, specifically.
Oh.
Warfarin doesn't have a specific reversal agent.
No, I'm not asking specific reversal. Like you have given the patient on warfarin and you need something because it's an emergency surgery, right? Vitamin K will take time. So any other thing or the blood product or anything
PCC, we will use prothrombin complex
Mhm.
concentrate.
So what are the different types of PCC,
So there is two types of PCC, 4 complex PCC and 8 complex PCC.
4 and
4 complex and 8 complex.
8.
Sorry, 4 complex and 6.
6. Okay, what are the component of 4 complex PCC?
So 4 complex is 2, 7, 9, 10.
So what will be there in 6 then?
With protein C and protein S.
Okay, what are the specific reversal agent for apixaban?
Specific reversal agent for apixaban is apixaban is PCC number.
PCC, any drug
Yes, ma'am, there is andexanet alpha.
What is the specific reversal agent for dabigatran?
Idarosizumab.
Okay, we'll stop you here. A long Viva, no? How you did, Dr. Nupur?
Ma'am, mostly I think I know what they do, but the scorings I have forgotten. Like because I don't calculate them myself. That's why I've forgotten the scoring. I know most of.
I would say first part anemia and all you had read well. I know you have correctly picked up the article which I wanted you to know. So this is the article you probably had covered it up.
No, ma'am, I actually read from physiology because I had not read reproductive physiology for a long time. So
No,
I
not
had.
anemia. Not asking the initial
Okay.
RBCs and all. This article you have 100% you have read this. I was asking anemia.
Yes, ma'am, I had read this long back. Yeah, blood circulation.
So you're exactly answering whatever I wanted to listen. What are the causes of anemia? And this has been recently asked anemia. So causes of anemia was fine. How do you minimize the preoperative strategy for minimizing the bleeding? Again, you told the causes correctly. Then intraoperative also few points you missed, but overall it was nice. Cell salvage. So here a bit, I would say indication includes the anticipated loss is of more than 1 liter or 20% of the blood volume. And the contraindication, there are relative contraindication, as you correctly mentioned. In sickle cell they have used, but there are few relative contraindication, not absolute. So clotting agent, irrigation solution if the patient is on the following drugs, if the malignancy is there primary at the operative side of FEO, ascites and sickle cell. So these are relative contraindication to cell salvage. Again, antifibrinolytic, I was asking you crash 2 trial and you mentioned that also correctly. Okay. Initial PAT hemoglobin, you could have done a bit better. It's directly physiology. I also could make up. But one of the candidate again was asked, this is the first chapter of podcast and directly they were asking one by one the question. So biliverdin will be converted to what? That entire thing you have to again go and revise once.
Yes, ma'am.
Yeah, that was not, means I would say not a fail or a bad, but it was just average for you. Okay.
Okay, ma'am.
Then the most important thing, which is very important and you didn't answer, is this question. The next question I asked. Can you see my screen?
Yes, ma'am.
So whenever this question is put, this actually I always teach from a update article. Okay. In the update article, they have picked up, I will also share with you in the group. They have entirely written everything in that article. That is the best article to read. So when you have to take a decision, you have to estimate the risk of thromboembolism. Then you have to estimate the risk of bleeding. Then you have to see the timing of anticoagulation and interruption depending on what the anticoagulation is on. And then you consider if the patient has to use a bridging therapy, yes or no. Right?
Yes, ma'am.
For that, for the risk of thrombosis, there is something called as so the risk of thrombosis, there is something. Yeah. So these are the preoperative risk, thrombotic risk. So if the patient is on mechanical heart valve, atrial fibrillation or VT, they are the high thrombotic risk patient. If the patient is on mechanical valve, you have to see which type of valve. If it is a mitral valve, any type of mitral valve is bad. Okay. If it is a aortic valve, then either caged valve or tilting disc. Or the patient has TIA within the 6 months. If you consider for patient as AF, so our patient falls in this category. If the CHAD S2 score is between 5 to 6 or CHAD A to DS2 VAS score is between 7 to 9, patient having TI in the last 3 months or and RSD. These are again the high thrombotic risk. And venous thromboembolism within 3 months with protein CS3 deficiency and antiphospholipid antibodies are the high risk. So for us, the patient is a high risk since the patient has a suppose patient is having AF, I gave you the half scenario. If I would have told the patient is having active AF and the patient has TR 3 weeks back, so it falls in a high risk category. Then you know what is the component of CHADS A2 VASCO. So CHF, H for hypertension, A2 for H, they have given 2 points. T for diabetes mellitus, S for stroke, again 2 points. VASC is vascular disease like previous MI, peripheral artery disease, aortic plaque. And if the age is between 65 to 75, they have given 1 point and female is 1 point. Then you have to look for the bleeding risk. So the high risk bleeding is abdominal surgery more than, but since it's a laparoscopic surgery, I would not consider it as a high risk. So it's abdominal surgery at the time, it is a laparoscopic surgery. So to me, it appears to be a moderate risk. So for again, they have given who are the patient of what has bled is not the surgical risk, bleeding risk. It is a depending on the patient, the risk has been defined. H for hypertension, A for abnormal RFT, LFT, S for stroke, B for bleeding tendency or predisposition, L for labile INR, E for elderly more than 65, and D for drugs or excessive alcohol. Okay. So accordingly, they have decided whether to go for a bleeding, increased bleeding or decreased bleeding. So next, I asked you about apixaban. Apixaban will depend on the creatinine clearance also. So if creatinine clearance is decreased, it has to be reduced 3 days. If it is increased, then it has to be in 48 hours. Since the patient has high thrombotic risk, we'll go for a bridging therapy. Okay. And then the question I put to you was this. This is the apixaban which I was talking about. It was on 2 mg BD. Creatinine clearance is normal. Then same thing, 48 hours or 72 hours depending on the scenario. So next I went, so you have to remember all the things. So one of the common doubt people ask is thing RA, anticoagulation and RA and anticoagulation surgery different? Though there are a bit of overlapping, few differences are there. So it is better to remember them separately. Okay. So I asked you about warfarin. Yeah. So this is again very important thing. What happens to warfarin? So if you see the patient is on warfarin, Then if you discontinue, it takes 5 to 14 days. Okay, that is why they have kept up to 5 days at least. Vitamin K will act 6 to 24 hours to correct INR. So if you are doing with vitamin K, it is not an immediate reversal if it's an emergency. Then come fresh frozen plasma. Again, it takes 12 to 32 hours. Right. So best is PCC. PCC will take 15 minutes. After 10 minutes to 1 hour infusion. So this is the fastest way to get it done. And PCC has 2 types, 4-factor, 3-factor. I don't know. I think you have read 3 as 8. It is 4 and 3. 2, 7, 9, 10. And here it will come 2, 9, 10. 7, you have to give a separate recombinant factor 7 or the Novo 7. Okay. So this is 4 complex. This is 4-factor, 3-factor. There is no 8 and 6. So this I've already mentioned. And finally, the reversal agent. This also you answered correctly. Initially, you didn't come up here, but ultimately you could pick up here. So this is a must kind of article. You have to read. I will share with you. But this is a very important. And this is one of the favorite topic they take you on. How do you quantify the risk of bleeding? How you quantify the risk of thrombosis? Whether to go for a bridging therapy now, if yet, when to stop, when to start, what about what, whatever, NOACs, DOACs, this is a kind of a very favorite question of EDAIC.
Ma'am, but usually the NOACs don't require a bridging therapy, isn't it? I'm just asking, ma'am.
That is also a thing. NOACs doesn't require a bridging therapy until and unless the patient is a very high risk of thrombosis, then only you do. Else it's not. Like
So, ma'am,
as such in a
if to answer this question, just I say like the thrombocytic risk and then mention the score, then bleeding risk, then I mention the score, and then I put it into the question scenario, whatever they give, and then answer accordingly.
Then you say, yeah, if it is a very life-threatening thrombosis that's there, then only you go for a bridging therapy, else for NOACs it is not needed. That you are right. Yeah. So in such question, actually what they are giving, no, they are also like how I created the scenario, they also are creating the scenario. So if there is no clear-cut say on whether to put it on low bleeding or high bleeding, like laparoscopy, it's a abdominal surgery also, it is a laparoscopy surgery also. So definitely to me, it appears moderate, to you it appears severe. So that you can put your, like how you mentioned, to me it appears severe. So I can say, no, it's a laparoscopy, to me it appears moderate. So it's and few things are overlapping. Your reasoning is sufficient to bypass them. Like they will be happy. They will not counter you. Or they will themselves say, to me it appears moderate. Okay, it's moderate. Then you go ahead of how next you plan.
Yes,
Okay?
ma'am.
Yeah. So this is very important, but I would say you have to, and the best source I suggest is go for this up-to-date article that is complete, and just remember the charts. Even if you don't have time to get in, just remember the charts. That's nearly complete. Okay.
Yes, ma'am.
Yeah. So I actually found one area where you are weak at. So you need to study this topic properly. A bit on I would say there is a scope of improvement in physiology for you as well. Like few things I was not very pleased with your answer. Like I asked you about the breakdown, that was not very good. Cooperativeness, binding. Initially you told cooperativeness. I think I corrected cooperative binding. Then you jump to cooperative binding. Once a bit of refinement is needed. And yeah, here again, the first question, your voice was very constant, very good. But in the second question, again, it was flickering.
Okay, ma'am.
Yeah. Fine. So who is coming up for the next? Or you want a break? Now I need a break. We'll take at least 5 minutes break. Okay. And who is coming up next? That also you put and then we go off. Dr. Sarah, are you happy? And Anu, Dr. Sara, Aditya and Nupur had second round by now. Dhanya also had second round.
Ma'am, I'm feeling very underconfident. I'm just thinking my knowledge is not sufficient.
Dr. Sara, point is, see, this the session here is not to put you down or make you harass. Okay, this
No,
is a
ma'am. I'm finding a lot of areas I need to work, because I haven't read all these articles you're pinpointing, and that's making me really depressed, because all I have done clinical from the FRCA books. So, and I have don't much time to study all these
see,
things.
Dr. Sara, there is no point of getting. Point is, your knowledge is fine. If you update, your phone has one software.
Mm-hmm.
You reboot it and update it. It's not that you don't have a phone.
Mm-hmm.
So you
Okay.
have the knowledge. You need to update it. See, the books, why we do not teach from books is those books are, most of the books are older. Elizabeth
Yes.
Captain has come up with the update, which I do like for teaching.
Mm-hmm.
At the same time, EDAIC people do not ask much on Elizabeth Collier. It is good for FCI, but not for EDAIC.
Mm-hmm.
EDAIC is, there is no defined I think we had one girl, Pratibha, she got very good marks in FCA, then she sat for EDAIC. So I was just asking him how you found two exam. Her answer was FCI is a very well-defined exam. They know this is a syllabus, this is what they are going to ask.
Mm-hmm.
EDAIC is kind of a very random exam. They can ask anything. There is no boundary to it. So
Mm-hmm.
there is nothing to feel low. At the same time, that is what I could pick up from your first Viva itself. Your knowledge is good, you're hardworking. At the same time, you never found the correct source of learning.
Yes, yes, that's what I find the same, because had I got these articles before, I could have read them all and could have answered more confidently, and the technical things, like you are asking scoring systems and things like this.
It's okay. But that's why I
Okay.
told you have
Okay.
exam in. So now I would suggest that you have to double X your speed and double X your.
Mm-hmm.
This
Okay.
is, I told you, I could pick up from the beginning only. I was telling you, if you see other people Viva, you will understand because they are with us for a very long time. So now
Yes.
they've understood how to study how to crack this exam, and what all to refer to study.
Yes. Yes.
Depressed, but
Mm-hmm.
you try to pick up
Mm-hmm.
fast because you have less time. So you have to work more. Just
Mm-hmm.
they get back again. But no
Mm-hmm.
issue. Come up for the next Viva. We'll see. At least something you'll answer, no?
Okay.
Yeah. So we will get back in 4 minutes exactly because we already lost 3 minutes. So exact in 4 minutes we'll be back.
Mm-hmm. Okay.
Hi, Dr. Sara. Hello. Am I audible?
Yes, you are audible.
Yeah, Dr. Sara, question for everyone, question in the chat box. So you have a 5-year-old boy who is undergoing an elective strabismus surgery under general anesthesia. He has a history of motion sickness but no prior surgery. His parent expressed concern about the post-operative vomiting as his oldest sibling had severe nausea vomiting after a previous surgery. Okay? You there, Dr. Sara? Dr. Anu, are you happy to take up this question? I think Dr. Sara is not around. Dr. Anu, Dr. Dhanya means who never had the second round. Anu left. Okay. Dr. Sara, you there? Anyone else coming up? Anyone? Because we are only left with, yeah.
Ma'am, I'll take up if no one is taking.
Fine. So you have a 5-year-old boy who is undergoing an elective strabismus surgery under general anesthesia. He has history of motion sickness but no prior surgery. His parent expressed concern about the post-operative vomiting as his older sibling had severe nausea vomiting in the past. Right? So can you tell me what are the physiological mechanism involved in vomiting?
So, vomiting is divided into two phases, the pre-ejection phase and the ejection phase. And
I'm not asking you. I'm not asking the phases here. I'm asking what are the
okay.
physiological mechanisms? Like what are the various?
Yes, ma'am. So it is the vomiting center, which is located in the medulla, and that is mainly responsible for vomiting. And it receives signals from the chemoreceptor trigger zone, which is in the area postrema, which is outside the blood-brain barrier. So it responds very quickly to any emetogenic stimuli in the blood. And the chemoreceptor trigger zone again receives stimuli from various drugs, from dopamine and from the vestibular apparatus. Then the vomiting center again it receives stimulus from the gut, uh, 5H through the 5HT3 receptors, and then it receives the vomiting center also receives stimulus from the vestibular apparatus through the H1 receptors and the muscarinic receptors. Then the vagus nucleus, the nucleus tractus solitarius, it also sends impulses to the vomiting center through the H1 and the neurokinin 1 receptor. And then there are cortical higher centers which respond to pain, smell, sight, any emotion, and they relay to the vomiting center. And all of this then trigger vomiting.
Okay, fine. So, just one second. Yeah. So, can you tell me what are the phases of vomiting?
So phases of vomiting there are essentially two phases, pre-ejection phase and the post-ejection, pre-ejection phase and the ejection phase. So in the pre-ejection phase, what happens is the muscles, or there's a stimulus which is going, and then it is all the muscles are then contracting. So there's nausea and there's
You say
reduced
muscles
gastric.
contracting. Can you tell me what exactly which muscles you are talking of?
The muscles which contract are the pharyngeal muscles, the pharyngeal constrictors muscle, which are the pharyngeal constrictor muscles, which are the palatopharyngeus, stylopharyngeus, glossopharyngeus, and the oropharyngeal muscles. So that is the pre-ejection phase. Sorry, there are three phases: pre-ejection, and then there is retching. So retching will happen when there is a deep inspiration and it is followed by closure of the glottis. And then there is contraction of the diaphragm and the intercostal muscles against a closed glottis. And the alkaline contents of the small intestine, they get mixed with the stomach, which increases the pH of the gastric fluid. And then the intrathoracic pressure will then compress the esophagus. And then finally is the ejection phase where the glottis remains closed, the pylorus contracts, and the the lower esophageal sphincter, it will relax, and there will be increase in intra-abdominal pressure, which will push the gastric contents into the esophagus. And the likewise, when the soft palate will also occlude the nasopharynx, which will prevent the reverse peristalsis, and finally things will get expelled out of the mouth.
So what are the risk factor you can say in this child?
So, in this particular child, the risk factors for post-operative vomiting would be strabismus surgery, because ophthalmic surgeries, especially strabismus surgery, is more prone for post-operative nausea, vomiting. He's got a family history as well because older sibling had, and he's got a history of motion sickness as well. So there are three risk factors in this child, and also he's 5 years old. So he's 5 years, so he's more than 3 years.
So what is the scoring system we use in pediatric patients for post-operative nausea vomiting?
The scoring system which is used in pediatric patient is known as the post-operative vomiting in children score, which is the POVOC score, which has four criteria. One is the duration of surgery, which is more than 30 minutes. Then strabismus surgery, history, previous history or family history of post-operative nausea, vomiting, and age more than 3 years.
Good. So, how many, how you're going to prophylaxis to this?
Ma'am, your voice is breaking up. I didn't hear the last question.
How many, like, how are you going to do the prophylaxis?
So it is dependent upon the risk factors.
Hello.
So, yeah, hello,
For this,
ma'am.
yeah,
Yes,
for
ma'am.
this kid, what prophylaxis you're going?
So because he's got this child has got three risk factors, so I'll go for two antiemetics, one 5-HT3 antagonist and one dexamethasone, and I will go for opioid sparing technique and preferably use total intravenous anesthetic technique.
And one more important strategy that you have to maintain is
Uh, Adequate fasting of the patient.
liquid fasting.
Fluid, give fluids through the patient. Avoid prolonged fasting, and resume oral
Complication.
intake as soon as possible.
What are the common complication of post-operative vomiting in children?
So complications can be divided into two types, like patient-related factors and uh, hospital-related. So patient would be because of vomiting, there will be dehydration, there will be electrolyte imbalance, then distress to the patient, there can be wound dehiscence, chances of infection, bleeding, sepsis, and hospital related would be because it will lead to increased morbidity of the patient. So there will be prolonged hospital stay and increased bed requirement, delayed mobilization of the patient.
Okay. Suppose you have a 65-year-old male, history of type 2 diabetes, GRD, and obesity, is listed for elective laparoscopic inguinal hernia repair.
Yes. 65 for
Yeah, will check those. Yeah.
okay. Yes, ma'am. I've got the question.
Fine. So what are the physiological effects of fasting on gastric emptying and metabolism?
So, fasting it fasting will increase the gastric emptying time. It will reduce the stomach contents. Uh, mm, it will reduce the distension of the stomach. Uh, gastric volume and pH will also, sorry, gastric volume will reduce, but pH will,
So which are the food that slows gastric emptying?
solid food will
Type of
reduce,
solid.
sorry,
Which type of solid food you mean? Carbohydrate or
fat containing food is at the most, they will reduce the gastric emptying the most.
and what happens due to prolonged fasting?
So prolonged fasting will lead to anxiety, distress, dehydration, and then insulin resistance, which will lead to again hyperglycemia and stress response. Um, so prolonged fasting is not recommended.
To tell me
So,
what are the predisposing factor for aspiration?
so predisposing factors for aspiration can be patient-related factors and surgical related factors. So and anesthetic factors. So patient factors can be if there's a reduced airway reflexes like in head injury patient, any intoxicated patients and patients with bulbar palsy. Then patients with full stomach like any obstruction, uh, patients with inadequate fasting, then delayed gastric emptying, which can be there for opioids, any autonomic dysfunction like diabetes, CKD, pregnancy. Then if the lower esophageal sphincter is dysfunctional, like in pregnancy, abdominal distension like ascites, obesity, then the gastric esophageal reflux disease or hiatus hernia. Surgical factors, if it is an emergency surgery, if it is a GI surgery, laparoscopic surgeries, if it's a Trendelenburg position. Anesthetic factors would be light plane of anesthesia, use of supraglottic airway devices, especially first generation, and general anesthesia itself, and sedation and general anesthesia. Then use of propofol because propofol will blunt the airway reflexes.
Dr. Nupur, what is Mendelssohn syndrome?
Mendelssohn syndrome is aspiration aspiration pneumonia, which is called severe aspiration pneumonia, which is defined by the volume of gastric aspirate volume more than 25 ml with pH less than 2.5. It most commonly occurs in pregnant patients.
So if the patient is not fasting, then how you are going to modify your induction in this patient?
So if the patient is not fasted adequately and if it is an emergency surgery, so my techniques would be preoperative, intraoperative, postoperative. So preoperatively, I can administer prokinetics like metoclopramide, or I can give drugs like which will reduce the gastric acid secretion. Like,
Nupur,
yes, ma'am.
Dr. Nupur, my question is, how would you modify induction in this patient?
Ma'am, I was coming to that for modified rapid sequence induction of the patient.
So how do you
So
do that?
in modified rapid sequence induction so classical rapid sequence induction technique was patient was like the cricoid pressure was applied from the start of induction till the tube was inserted and the cuff was inflated. But in modified rapid sequence induction, after the administration of the induction agents, modified ventilation can be done as the airway pressure is less than 20 centimeters of water. And in classical technique, only the induction agent and muscle relaxant, fast-acting muscle relaxant was administered. But in modified rapid sequence induction, we can administer a little bit of opioid as well. So fentanyl, propofol or any induction agent is whichever is the choice, and then fast-acting muscle relaxant of choice. My choice would be roxuronium, as I can reverse it with Socamadex, and uh, apply cricoid pressure. And but cricoid pressure is also controversial now. If it is hampering the view of the laryngoscopy, it should be removed.
Would you like to do any focus before you take up the case?
Yes, a gastric ultrasound to
Can you tell me the
see. So this is the ultrasound of the gastric. I can see the gastric antrum, can see the aorta, the pancreas, the liver on one side, and I can see some, the gastric antrum looks dilated, and I can see some starry, so solid food materials in the antrum. It looks full.
Okay. Fine. We will stop you here. You did.
All right, then GI physiology is something which I have not read for a long time. So
Yeah, that I could pick up. So initial I put this article, it's a recent article, 2022 article from Pediatric Post of Vomiting published in ATOTW. So I was asking you the physiological pathway of vomiting. So exactly you told me what is written here. So nothing to add for here. Then I asked you about the risk factor. So that also you told correctly. You mentioned about the POVOC scoring correctly. Okay. And then the risk of the POVOC scoring to the incidence of POV was also correct. And since there was two, so you correctly mentioned you will go for a two prophylactic technique. Okay. And you also mentioned what not to be given, like you should avoid inhalational, and this question was also fine. Yeah. So this is the summary of various drugs. This also can be asked. And you correctly mentioned, actually, I don't have anything to add over here. But in the second question, I felt you were not very well prepared for the second question. You have not read it properly. Like, I will just tell you, I was asking you what is the physiological effect of fasting. So it depends on the type of the ingested material first. If it's a clear food, it will take less time. If it's a solid food, it will take a lot of time. Energy density. If it is a fat, protein, carbohydrate, it will have high calorie content. Okay. Then prolonged fasting will result in last class only we had discussed increased your ketone production, the phases of starving you, if you remember.
yes, ma'am. Yeah, I should
Increase
have actually told all
Yes,
those.
this is what I was asking actually. Increase in cortisol, increase in your ketone production, and decrease in insulin secretion, apart from dehydration, can cause an electrolyte imbalance. And pathophysiology of aspiration, that was fine. Mendelssohn syndrome also you told correctly. Then I asked you, how do you modify this again, Dr. Nupur? If I'm asking induction, you have to talk about induction. Don't go to pre or post. The problem is, the point is the exam. You might know this answer. That's why you are very enthusiastic to answer. But point is, the examiner will not interrupt you, and he will just let the time go waste, and he will keep on talking. So
Yes, ma'am.
yeah. So if they have asked induction, just go for induction. I will go for a modified RSI. Second thing, the concept on modified RSI, I would like to modify a bit. What was there in RSI? A fixed dose of the inducing agent and the relaxant was used. That is thiopentone and scoline, and as a fixed dose.
Yes, ma'am. There was a fixed dose which was
Yes.
used previously. Yeah.
Yeah. With modified RSI, they have made it to the varied dose according to the body weight. Plus, instead of thiopentone, even propofol you can use, or ketamine, you can use any induction agent depending on the patient condition per se. Okay. Most commonly used is propofol or thiopentone. Then second is the relaxant. It was choline only. Here they have put it as rocuronium. That was one difference. Second difference, as you correctly mentioned, there they never used to do any bag and mask. Here, a pressure of a APL closure up to 70 mm of edge, 17 mm of edge is allowed. You can do a gentle bag mask. Okay. So these are the two main differences between the RSA, because RSA also has been asked, I think, 2 months back. Rest was fine, I think. Okay.
Okay, ma'am.
Yeah. Then what was left is few questions which I will tell you. After hepatic physiology, we already mentioned drug metabolism in liver. If you open your podcast, chapter number 6 or 7, one is liver, one is kidney. You have to know those properly. What is the cytochrome P450 system? Which are the drugs that are metabolized fast, acetylators, slow acetylators, and halothane hepatitis. What is a entire? What are the genetic conditions where the things is get prolonged? So this is completely theoretical, but you have to learn it. Okay.
Yes,
Second
ma'am.
question is coagulation pathway. You should be able to draw the coagulation pathway. Peg, you have to draw what is, how does a TEG goes, the various phases of DEG. This also has been asked, what is the difference between TEG and ROTAM? Then what are the blood conservation strategy? Anyways, we already discussed. And one more thing I would like to discuss is on sickle cell. Though sickle cell has not been asked in very recent time, but you can expect a question on sickle cell. And why that is because this AGB has come up a guideline on sickle cell. Okay, and we generally follow the AGB guideline in 2021. So you need not go through the entire article. The recommendation you have to read and one box is there. Yeah. So they in the total, the types, common types of sickle cell anemia, which you already mentioned, and what are the acute sickle related complication in children? So they have given this entire as a box kind of thing, which you just go through it, read it once. Chronic sickle related complication in adult. So this is in one in children, acute sickle related complication and chronic sickle related complications. Okay. Then, so what all you have to avoid, that pain, dehydration, starvation, this all the same thing. Normothermia, you have to maintain, no pain, no acidosis. So just you have to go through this article once. And here, this is the most important thing, which in fact, rest you will get everything from other books, but this you will not get. So the suggested transfusion strategy before elective surgery, now they have told if it's a, they have classified as genotype, the surgical risk category, then baseline hemoglobin, and finally, what is the preoperative transfusion you need to do. Okay. For all the genotypes, if it is a high risk bleeding surgery, then exchange transfusion aim to a hemoglobin of 10. If it is a HBSS, the main variant, the dominating variant, then if it is a low or medium, then you look for the hemoglobin. If it is less than 9, then do a top-up transfusion only. If it is more than 9, then do a partial exchange transfusion. Okay. So you have to just remember this extra thing from rest, whatever you know is fine. Did you get it?
Yes, ma'am.
Yeah. I think one more article is there. Let's discuss quickly. Yeah, so this is another one. So this is in 2018, anesthetic management with a child with sickle cell. So what is sickle cell first? Here a bit on, you should know that by you already we discussed it, what happened in sickle cell. What are the antibiotic and vaccination you need to give in a patient who has sickle cell? Then what are the acute complication? That chart, whatever I showed you is complete. You can just refer to those chart. What is acute chest syndrome? They might ask you. And then anesthetic considerations. So the common surgeries that is done in age less than 18 years with sickle cell patient. And this also we have already discussed. No, children should be kept hydrated. You should give oral anticoagulant, oral fluids, put the case as early as possible. Here they have mixed it up. So like the hemoglobin is 10, hemoglobin is 9, if higher, exchange transfusion. So this part you just read from the other anesthesia I showed you. Okay. So top-up transfusion with a preoperative hemoglobin of 10 and SBSS of less than 30. So this part is older. You refer the anesthesia, the other one we discussed. Rest, as from any book you read, that same tonic way problems, the cell salvage is considered as a relative contraindication, whatever we discussed now. Okay. So what are the types of crisis? So just have a good overall knowledge on this. That's all. That is something new. What I wanted to add. Any question?
Exchange transfusion if hemoglobin is less than 9 and top up
Was more than
with the more than 9. Okay.
So that is a new thing that guideline or consensus has come up. Rest everything is same. Like for many book you study the same acute chest syndrome and what are the problems, what you should avoid. Rest everything is same. And polycythemia, I deliberately left. That is not much what they also have asked, but anything more they want to know is when you will do phlebotomy and in polycythemia, what are the problems? There are chance increased risk of thrombosis, thromboembolic risk is high, infection is high. So just basic, they're not going too deep in the polycythemia. That you can, that is an Oxford handbook, no? They're just given few points in each of the chapter. Just refer to it once, that's all. And if you don't find, then you let me know, I will just share some. So should we call it a day?
Ma'am, one second. This physiology in this topic we have to read from podcast only, right? This which you are telling hepatic and
Yeah,
kidney.
physiology completely master pass and podcast are sufficient for physiology pharmacology. So like you have
Okay.
come to liver and blood. So what we expect is you read the physiology of liver and blood, read the pharmacology of liver and blood, read the clinical of liver and blood, then you come to us for Viva.
Okay.
Because podcast and masterpass covers the most of physiology. So we randomly pick up some topic and ask, and we want that you can do on your own, this homework. But this
Yes,
article,
ma'am.
where to read, what to focus, because this is, if you do on your own, you will take a lot of time and you will have unnecessary anxiety. That is why we are helping you more on the clinical side. That doesn't mean that you will lose things on basic, and just because you are attending our class, you will only focus on clinical. So in between, that's why I was asking Nupur about some physiology. So I was just trying to jumbling around. So just for the completion's sake, but I'm not teaching because that you can read from book. It's a straightforward podcast and masterclass which you have to follow. Still, if you have any doubt in understanding some core concept, you can come to us. We'll teach you the core concept if you have any doubt.
Okay. Okay, ma'am.
So anyway, we are there over WhatsApp. So if you fail to, you can put a like personalized message or you can put in the group. Whatever doubt you have, which you didn't understand it here, because the topic is so much. Today I covered almost 13 topics. So, and that too in 4.5 hours. So it's not possible to take you through everything. So we can just give you an overview or can guide you how to read these topics. So still after you read and if you have any doubt, you can come back to us in WhatsApp. We are there for the, and me or my other colleagues or faculties. We are there to help.
Okay, ma'am. Thank you.
I just wanted to ask about few other topics like splenectomy. Is it important or we can just omit it?
See, if they ask you splenectomy, then what will come? Again, the vaccination. You have to do the vaccinated vaccination. Blood. You should not transfuse beforehand. Once it is ligation, again that conservative blood consumption, that thing will come up. Okay. Then nothing. That's all. And pain control. Because splenectomy is open case, so it will have a huge. Mostly it is open. It can be done with lap also, but for the then extraction of the specimen, they do a open. So and pain control.
Okay.
And what is why patient is having splenectomy? Either ITP or it is a sickle cell. Most common complication, most common indication. Sickle cell, we learn separately if a patient has sickle cell, how to start with external transfusion, how to make the patient fit and all. If it's a ITP, pre-operatively, you should not transfuse much of the blood products because whatever you transfuse, spleen will eat it away. So you should wait for the ligation of the vessel, then you transfuse. So what is the minimum thing that you go for a GA is 20K? Anything between 20K is okay. Then they might ask you what is RDP, what is SDP, what is massive blood transfusion. You should avoid hypocalcemia, you should avoid hypothermia, acidosis. So everything will follow the same what you study from some other bleeding case.
Yeah. And ma'am, among bleeding disorders and thrombocytopenia, like basics for any surgery, how much is required, and then for neuraxial catheters and for surgeries. And then bleeding disorders, should we read or just
Bleeding disorders, today we discussed among, see, wall movement factor, they had asked very long, I think 7 years back. Hemophilia, they
Okay.
used to ask 7 years back. So this topics, what I would suggest is go open your Oxford book. They have just given in one summary, like 5, 7 points, 10 points. Only
Okay.
read that much. Don't do extensive research. They will hardly ask what happens in hemophilia. So what happens in this time they asked what happens in polycythemia. You just need to it's not so deep like how we discussed for liver and all. They will not go into much depth. Just overall, what are the points you can remember in those topics? So sickle cell, thalassemia, hemophilia, Wall-Wyman disease, and thrombocytopenia. Even they don't ask. I think this much is sufficient. And polycythemia. Polycythemia, sickle cell, Wall-Wyman, hemophilia, thalassemia. 6, 5 or 6 of that. Sickle cell you read properly. And rest everything is just superficial. Like porphyria, already article is there, so I discussed a lot. But whatever you have, the background knowledge is sufficient. And rest, just know the points. Wall-Wyman factor, the how many types of there, which is the more bad one. And if there is there, what is the role of desmopressin? And that's all. Polycythemia, when you do phlebectomy, and what is the hydration has to be maintained. You should avoid all this acidosis. Thromboembolic prophylaxis has to be given. So the important points, that's all. Yeah, Dr. Aditya will share all the articles. That is not an issue. We will do it.
Thank you.
Thank you, ma'am.
Okay, then let's call it a day. And I hope you enjoy the class and you will study more and come up next week. And we will just update you what is there for the next week. Just give us some 3-4 hours, we'll discuss and we'll get back.
Thank you, ma'am.
Bye
Thank you,
bye.
ma'am.
Bye.